The President Doctor is Dr. Jayshree Deshpande Madam, Secretary Dr. Anuradha Palwankar Madam, and Treasurer is Dr. Alka Badbade Madam. Today, the first topic is treatable scenario in pediatric neurosurgery. The speaker is Dr. Saurav Samantray. Dr. Saurav is a renowned consultant pediatric neurosurgeon at SRCC Children Hospital, Haji Ali, Mumbai. He is doing dedicated pediatric neurosurgery since 5 years with exclusive pediatric neurosurgery experience in 12 years of neurosurgical career. He had done his fellowship at BJ Wadia Children Hospital, Mumbai, along with Great Ormond Street Hospital, London, and in UK also. His area of interest are in epilepsy surgery, surgery for spasticity, brain and spinal cord tumors, complex hydrocephalus, spinal dysraphism, and craniofacial surgeries. Dr. Saurav, please, you can start your session.
Good afternoon, everyone. Thank you very much. I hope I'm audible and
Yes,
without
yes,
wasting.
you are
Thank you for this
audible, sir.
opportunity to IIP Palghar, and hopefully in the next half an hour we'll go through some scenarios in neurosurgery where I believe there is light at the end of the tunnel. Some common ones, some uncommon ones, but things which can be treated and where children and families can be given hope. Okay, so is my presentation seen?
Yes.
Thank you.
Dr. Saurav.
Yes, yes.
Yeah, Dr. Saurav, 1 minute. I'm
Yes.
Dr. Hemant. Hello.
Sorry, yes. Sorry,
Yes.
I lost you.
Problem with neurology is your difficult terms are not understood, so
Yes.
people don't understand anything. So
Sure.
whenever you think you have used a less common term, explain it in
Yes.
simple English.
Yes, so
Otherwise,
actually,
it will not enter
I
our
have...
brains. We are small people. Okay, thank you.
Well, so yeah, definitely. So I've tried to keep it very simple, very little theory. In fact, I've just tried to show more pictures and videos so that hopefully there is a longer impression and better understanding. But please feel free to stop me anywhere in between if you think there is something that doesn't sort of connect. So yes, I am a pediatric neurosurgeon and an epilepsy surgeon at the SRCC Children's Hospital.
Excuse me,
And
can you make it full screen? Yeah.
Yes, can you see it now?
Yeah.
Full
Yes,
screen?
yes.
So basically, pediatric neurosurgery covers a whole gamut of different malformations and disorders. I think it's very difficult to really cover everything in half an hour today, given the kind of work that I'm doing here. But I think what have tried to cover is these 5 subspecialties in neurosurgery, over which I'll show some illustrative cases just to show that there is forms of treatment that modern neurosurgery can offer. So we'll talk about spinal dysraphisms, craniofacial disorders, neuro-oncology very briefly, epilepsy surgery because that is my main area of interest, movement disorders, and of course, hydrocephalus, bony spine malformations, spasticity, so on and so forth. Hopefully, we can meet again sometime soon and we will have a further discussion. So today I'll only cover these 5 topics. So spinal dysraphisms, I think in your OPD practice, I'm sure all of you see spinal dysraphisms. What I want to sort of clear the air about is the whole terminology and how different kinds of disorders exist, which are all unfortunately put under the umbrella of myelomeningocele. So this is a very broad classification. I want to point your attention to the fact that myelomeningocele or open dysraphism is only one part of these so many different types of neural tube defects. So it is safe to actually call everything neural tube defects or spinal dysraphisms rather than the usual binary classification of MMC and lipo-MMC, which I see many people referring it to, including neurosurgeons. So honestly, it's better to call it open neural tube defects and closed neural tube defects. Now, very quickly, patients will present to you with either neurological problems orthopedic problems like the ones mentioned here, which could be either in the foot or it could be in the spine, or there could be urological problems. So this is the neuroorthopedic syndrome, which sort of covers tethered cord syndrome. Now, before I go to the different cases and pictures, these are the two workhorses. Without this, in today's day and age, doing spinal dysraphism surgery, according to me, is a sin. One, on the left, like you see, this is an intraoperative picture from our monitoring team's laptop. These are the various muscles which are being mapped during surgery. So, spinal dysraphism surgery, spina bifida surgery, even if the child has neurological weakness or deficits, should be done under intraoperative neuromonitoring. Needles are poked into various muscles and recordings are taken. And during surgery, we hope that all the preoperative recordings are maintained at baseline. And if there is a problem, then we know that there is a problem during surgery. Gone are the days when spina bifida was operated without intraoperative neuromonitoring. The second most important thing is this: when you look at the picture, look at the resolution. This is a spinal cord which has been cut here at this end where my cursor is. And all the white twigs that you see here are basically cauda equina nerve roots. This is the dura which I have opened. All of this needs to be done under a good operative neurosurgical microscope. Without that, sometimes you can do very minimal or basic disorders with an operative loop. But when you're doing a 3-4 hour surgery, wearing a loop and looking down and bending your neck tires the surgeon. So this is like a brain tumor surgery or a spinal tumor surgery. Has to be done with a microscope if you wish to give good outcomes. So with this, I'm going to the common disorder, myelomeningocele, which is the open neural tube defect. This is what, and this is the only condition which should be called a myelomeningocele. This is one of the children which I had operated a few months ago. I will come later to the description of this disorder as to why only this should be called a myelomeningocele when you see it. Now, this might also end up, this is again a neonate as you're seeing, this might also end up being called a myelomeningocele, but it is not a myelomeningocele. Have a look at this and have a look at what I showed you before. There is a big difference. I'll come to the difference. So this is actually a condition called saccular limited dorsal myeloschisis. It is enough for you to at least remember at the end of this talk that every globular fluid-filled swelling on the back of a neonate is not a myelomeningocele. Again, this, even though it is huge, this is from my Wadia days when I had operated a case there in Wadia. This is again not a myelomeningocele. This is a terminal myelocystocele. Why these names are just not because of classification purposes. The difference is in the prognosis, the treatment, and the surgical approach. Myelomeningoceles are basically these. So what you see in a myelomeningocele is you see a neural placode, which means that your spinal cord, which was supposed to be closed and into a tube, is basically open like a book, and you see the neural placode at the surface. And and then you see a junctional zone. So basically the spinal cord and the skin are fused with each other. In embryology, which I've not gone into the details, the spinal cord separates from the skin. So the spinal cord and the skin were one layer. They were the ectoderm. They separate during embryology to develop into cutaneous ectoderm and neuroectoderm. In myelomeningoceles, the spinal cord could not separate from the skin, and it is exposed because it stays open like this. So CSF is leaking out. Only this disorder is called a myelomeningocele. And as you know, myelomeningocele children generally present with neurological deficits right from birth. You always should check the anus. Look at the anus of this child. It is so patulous and loose. So this is a myelomeningocele, which overall has a slightly poorer prognosis depending on what level the defect is. And it also has to be operated as an emergency because it is leaking CSF. None of the disorders that I showed you before, or this one, is a myelomeningocele. It is not leaking CSF, and in fact, if operated well, these children will walk on their feet and will possibly be as normal as I and you. So therefore, the prognosis and the treatment and the approach differs. So you always remember, for safety and also for logic, classify spinal dysraphisms into open neural tube defects and closed neural tube defects. I'll quickly run through some examples. Now look at this. This is just a dystrophic skin patch. It's not uncommon for most of these children, if they have normal neurology, to just get prognosticated that nothing is going to go wrong because it's just a small patch. It's not harming the child when he is young. But when you see the scan, you see that there is already syringomyelia. And this condition, the spinal cord should have ended at this level, the L1, L2 level. It is ending here. So it's a low-lying conus or something called a retained medullary cord. Again, all that I'm trying to show is, forget the terminology. What I'm trying to show is these subtle things which are there on the back should never be ignored. Now look at this. This is a sacral dimple and a skin tag. Again, the conus, which should have ended at around this level. This is the conus. The gray shape, this is the conus of the spinal cord. The spinal cord should end at this level. But you see, the spinal cord is going right up to the sacrum. The lumbar, these are the lumbar vertebrae. And these are the, if you see the labeling, this is L5, this is L1. Spinal cord should have ended here. This is the sacrum. The spinal cord is coming all the way down here. So again, you can't ignore these markers of spinal dysraphism. Now look at this. This was actually a very, very good pickup by a pediatrician from Nashik who had referred. In fact, if you see, you could just send this child home as normal. But there is a tuft of hair on the back. And if you look at the spinal cord here in the MRI, there are two spinal cords. So this is a type 2 split cord malformation. So again, screening with MRI. And remember, the only investigation to screen for spinal dysraphisms is an MRI of the spine. No ultrasound, no X-ray, because nothing will define. You see how many different types of disorders are existing. All of this cannot be delineated by a ultrasound. So you might do an ultrasound for your interest, but if I have to operate and if I have to diagnose the variety of disorders that exist, I need MRI and only an MRI. Now look at this again. This is a small tuft of hair in a dystrophic skin. Now, this is something called limited dorsal myeloschisis. There is no swelling here, but there is a track going from the skin and inside the spinal cord going and attaching to the spinal cord. Now, spinal cord again is low lying. This is L5, this is L4. Spinal cord is coming at L4. It should normally end at L1, L2. Now, again here, this, as you see, they are hypotrophic. Practically, the child doesn't have any buttocks and there is an asymmetry. I think the picture doesn't bring out it so well. Now, this is an example of caudal regression syndrome or sacral agenesis. Now, look at this. Look at the labeling. L1, L2, L3, L4, L5. There is no sacrum. I'll go to the previous. Look at this. The sacrum should be a long bone like this. Sacrum itself has 5 components, but look at this. So this is sacral agenesis, where in addition to the lower end of the spinal cord not getting formed, you can see the bladder is also big. This white bit is the urine in the urinary bladder. It looks big and thickened. And behind the bladder, you see all of these black things. These are feces loaded in the rectum and the sigmoid. So basically, this is caudal regression syndrome, where the child has, in addition to neurological problems, bladder and bowel problems as well. And in all of this, as you will see, there are wires fixed to the patient, which I want to show you again and again. Look at that. Wires going into the anus, wires going into the head. So all of them are intraoperative pictures just before surgery where we have done neuromonitoring. Now, coming to an interesting case before I move on to the next topic. This was a 15-month-old male who did not move his legs since 2 months of age. Okay. Now, just quickly, just to show you, this was the neurology. The mother was examining him in my OPD. So this is pre-op. So the child didn't move legs since 2 months of age. Now, why I thought of discussing this case here is that this child from 2 months to 15 months of age was seen by multiple doctors, pediatricians. He even had a brain scan done because, it's common for pediatricians to think that someone with bilateral lower limb reduced movement could possibly, even though remember, he is hypotonic. He is not hypertonic or spastic in his lower limbs, but people think of CP. They think of spastic diplegic CP. So he had a brain MRI done, but now this, see, there is nothing on the back also. So I understand why a spine was never done. A spine imaging was never done, but look at what the spine shows. He had a congenital spinal tumor. So basically, he was born with this tumor. That is the reason he was not moving his legs practically from the day he was born. But 2 months is when he was flagged up to the doctors. It is a mediastinal mass and a spinal mass, and this proved to be a teratoma. So it was a benign lesion. If we had operated, so we operated on him, but we operated a bit too late. He hasn't made a very significant recovery because for almost 1 year, the spinal cord was compressed with this mass. We obviously operated it in a team with the general surgeons here. So always image the spine with lower limb neurological deficits. So this was not spinal dysraphism. Sometimes the skin can be completely normal, but remember that lower limb problems mean that you have to image the spine. Quickly, moving on to craniofacial disorders. Craniofacial disorders can be classified into non-syndromic craniosynostosis, where you just have one problem. Like you see here, a coronal suture is absent. So it is a unicoronal craniosynostosis. And look at the eye here. It's slightly flattened, the eyebrow is raised. This is the sagittal synostosis. You see the sagittal suture is absent. and the head is long. So basically, the skull never grows perpendicular to the fused suture. It always grows along the direction of the fused suture. Hence, in sagittal, it grows parallel to the sagittal suture. Hence, you have an anterior posteriorly long head. These are good cases to operate on. The primary reason for operation in these cases is cosmetic. Seeing raised intracranial pressure or seeing delayed development is very, very rare. But yes, generally they should be operated around 9 to 12 months of age. However, if an early diagnosis is done, endoscopic or minimally invasive surgeries can also be done between 3 to 6 months of age. However, there is always a debate about what is better, an endoscopic or open. That's beyond the purview of this presentation. But this is non-syndromic craniosynostosis, which are simple. Now, these are the more difficult craniosynostosis cases which we treat at our center, which needs a whole team to treat it. A neurosurgeon is only a part of a big team that has to treat. This child was being treated by a neurosurgeon, a plastic surgeon, an ENT specialist, a sleep physician, respiratory disorder, and pulmonologist. Now, you can see this child has you see retruded malar eminences. The maxilla is basically retruded. You see the head is pointing upwards. This is a German term called Kleibert-Skadel. Basically, this is syndromic craniosynostosis where multiple sutures are fused. Hence, the head is growing in any direction that is open. Proptosis. So this child snores throughout. This child has OSA. So, this child is going to need 3 to 4 surgeries over a period of time. So this is Cruzon syndrome. Now, this is Apert syndrome. Again, you see brachycephaly, the forehead is flat. Again, the malar eminence is retruded, and you see syndactyly coexisting with the craniofacial disorders. Now, this is a delayed presentation. This is very, very common in my clinic. There are so many children who, in fact, who are overall normal, but they have an abnormal head shape and certain subtle symptoms like breathing issues, multiple respiratory recurrent infections, snoring, and they've never had a sleep study done. And therefore, they will keep having central or obstructive sleep apnea for, you can always debate, this child goes to school, he's normal. Why do we really need to do anything other than cosmetic? But remember, cosmetic is also a big thing for this child because he was brought to me by his family because he was around 8 years old. He started asking his family, why do I look so different from my peers? And that is a big, big neuropsychological issue for this child, in addition to all the medical issues that a syndromic craniosynostosis will give him, which we are not aware of, like I talked about. Now, again, the complex surgeries that we do for this syndromic craniosynostosis is posterior calvareal bond distraction. So for that Apert syndrome, you see we have put distractors into his skull. So this is immediately after surgery. So what happens is this distractor is then twisted or turned every day by one whole turn. So in a day, it moves behind by 1 millimeter. After around 2 months, you see these two plates of the distractor are now distracted and we have expanded the volume. Look, the head was flat when we began. The head has expanded. So basically, in craniosynostosis, we are trying to give more volume to the skull. That is the first surgery that is generally done in the first year of life in most syndromic craniosynostosis. Later on, we'll have to go and operate on his forehead and try to bring it forward. And then, of course, he might need some other surgeries for his midface. I think I might have shown this case sometimes in the past. Again, a very delayed presentation of Cruzon syndrome, malocclusion of the teeth, proptosis. He was a 17-year-old boy, completely cognitively normal. So remember, he was told off by doctors and his family also thinking that he will never develop normally. But he used to have OSA, snores at night, and of course, to his eyes and breathing issues and the malocclusion of teeth. Here we did something called monoblock advancement using this technology. This is called the rigid external distractor frame. Very few craniofacial centers around the country do this. This again is fixed to the forehead and the face, and the family is taught to twist these screws and these ones so that the whole face is coming forward. Like I said, the whole face with the forehead comes forward. This is again done way more than just cosmetic indications. Look at the airway just before surgery. Then we have applied the frames. Look at the airway after surgery. In fact, the mother said for the first time, this child slept without snoring on the immediate postoperative first day in 17 years. So this child was denied treatment because first it was thought that he would not live. And if he lived, he would not, cognitively develop well. So I think this is where we, you as pediatricians and we as neurosurgeons need to communicate and say that there is, if we can treat blood cancers, if we can treat malignancies, if we can treat leukemias, lymphomas, CP, then these are neurosurgical disorders which have hope and light at the end of the tunnel. And children should not be denied treatment because of lack of awareness. Now, neuro-oncology, I know all of you know about brain and spinal cord tumors, but again, neuro-oncology generally is thought as, brain tumors are in fact the most common solid organ tumors. But I've always seen that there is a bit of a reluctance in treating, or more than reluctance, there is hopelessness in treating brain tumors, because it is believed that once the brain gets affected by a tumor, surgery is going to take a toll. And then after that, most of these tumors are bad. Now, this is where I need to chip in that I think you need to treat brain tumors, which are in fact, like I said, the second commonest malignancy to affect children, and the most common solid tumor to affect children, with hope, because many of them can be treated and treated well such that they can have normal lives. And the other tumors, which are at various degrees of malignancy, they can then be treated like so many other tumors that we are treating. So now look at this. Now there are two kinds of tumors: infratentorial, supratentorial. What do we call infratentorial? This patch here, this is called the tentorium on the MRI. Tumors beneath it, basically tumors in the cerebellum and the brainstem, are called infratentorial tumors. So look at this tumor here. This is the post-op scan. So don't look at this at the moment. Look at this. This was a huge tumor. In fact, you can't see normal cerebellum or cerebellar vermis at all. This is the brainstem. And of course, this tumor is causing dilatation of ventricles or hydrocephalus. This is the immediate post-op scan. This child had actually presented to me like this. He was operated at some other center where they could not reach the tumor. And also he was 12 months old when he came to me. So we specialize in treating infantile tumors. Definitely these are high-risk surgeries, because removing this whole tumor, in fact, reaching the tumor itself can lead to extreme blood loss in rare cases. So we need a very good team of pediatric anesthesia where they understand blood volume, where they understand the nuances of these kind of surgeries. But he was prognosticated to say that, this is a bad tumor, can't be completely removed, occurring at 12 months of age. So possibly the prognosis is very bad. We managed to remove the whole tumor. Like you see, this is a contrast scan. There is no tumor. Why I have brought up this case is this is 3 years after surgery. This was a benign tumor, a juvenile pilocytic astrocytoma. With a tumor that displaces cerebellum, compresses the brainstem like this, you would possibly think that this child will not develop normally. But this is his balance. Look at his coordination. Look at his speech at 3 years. And this is 3 years. Obviously, he was very lucky. This was a benign grade 1 tumor. He's completely neurologically preserved, despite the fact that such a big surgery was done on his cerebellum. And in fact, a part of his cerebellum was removed as well. That is where neuroplasticity. Children are so magical. They are so fantastic. Their brain is neuroplastic. Hence, they can sustain insults and still have the capacity to recover. Now, look at this. This is a supratentorial tumor. It is in the cerebellar hemispheres. What is critical about this tumor is that this is very close to the motor area. On the opposite side, this is the motor strip. So you can see this tumor is compressing the motor strip. Now, we obviously went. It is not so difficult to reach this tumor. This was a bigger child, but the risk in this child was if we try removing so the first rule in all brain tumors, like any other tumor, is if you can remove the whole tumor completely. But in the brain, the problem is sometimes if we try to remove more than the tumor, we end up damaging white matter tracts and critical structures like the motor cortex, which will then leave deficits. That is the problem why brain tumors sometimes are left behind. And obviously, it is always a matter of judgment. We managed to remove this tumor successfully. If you see on the left is the pre-op, which will show the tumor. On the right side is the post-op scan. So there is no tumor left at all. I don't think this is unachievable, but what was important was how is the child behaving post-op, because there was a big risk that this child could become hemiplegic or hemiparetic, and he's an 8-year-old. So this is the video of the child, 4th post-operative day. I'll show you the dressing. So see, he has been operated on the left side. His right side is moving very, very normally. There is a deficit on his left hand, but this is a pre-existing deficit from before because he was preterm and bleeding. Of course, we are now going to refer this child for proton beam radiotherapy. This has come out as a grade 3 ependymoma, but it is still a reasonably good disease to have, if I can call it good in the first place, because there is hope. If he receives, the first step is good removal. And after that, if he receives proton beam radiotherapy, there is a 70% 10-year survival, which I think we would accept for any other malignancy. So, this is about tumors. Quickly moving on to epilepsy surgery, because that is sort of my passion, my area of interest. We are the only dedicated pediatric epilepsy surgery center in the whole country. We have completed 100 epilepsy surgery cases since we started in October 22, a few months ago. Now, why surgical epilepsy surgery? So surgery for a medical disease. This is because of this. All of this is a problem. Living with epilepsy is a psychosocial burden. There is a quality of life problem. There is a sudden risk of death. And one third epilepsy cases become drug resistant. There will be neurocognitive decline as the epilepsy progresses. And drugs do not stop epilepsy, they only suppress epilepsy. They are not disease modifying. So the ILE also calls them anti-seizure medication rather than anti-epileptic drugs. So I'll be quick. So you have to remember, any patient needing more than 2 drugs, you have to refer the child to a specialized epilepsy center for evaluation and potentially try to help the child with some form of treatment. This is evidence in the favor of epilepsy surgery because of multiple randomized controlled trials, which has proved that many therapies offer seizure remission, but only surgery offers seizure freedom. I will quickly go to the different. So this is the whole team that we have: neurologists, neurosurgeon, neuroradiologists, psychologists. We look for data, we evaluate the data, and only when all of them come to a conclusion that we think epilepsy is coming from a fixed network in a fixed area of the brain, that is when we offer surgery to the patient. And this is our whole team at the SRCC Children's Hospital. It takes almost a whole village to do one epilepsy surgery. This is all the various technology that we use in terms of imaging, MRI, PET, intraoperative monitoring, neuronavigation, electrophysiology. I will show you, so these are the specialized MRIs. You see, these are the tracts which we bring up during surgery. So we do specialized MRIs, which we then use post-operatively to see that the tracts are severed. This is very important while doing these kind of disconnection surgeries. Now, these are functional MRI where we are trying to find function in the brain, where there is speech, where there is motor control. Then this is forms of PET where we are trying to find lesions in the brain. This is intraoperative neuronavigation. This is like the surgeon's GPS. I have placed a pointer on the skull and I am trying to find out where that pointer is in the brain, because remember, the brain doesn't show you any lesion. You might sometimes removing a small lesion from the brain could be like finding a needle in a haystack. So therefore, neuronavigation is a must for epilepsy surgery. Also, this is various forms of monitoring that we do. This is where our neurologist, Dr. Pradnya, is trying to find where the central sulcus is. This is after that I have disconnected. This is intraoperative. We are recording electrocorticography or EEG from the brain's surface during surgery. I remove lesions. This is intraoperative monitoring awake craniotomy. So this is where the child is awake. You see, there is no endotracheal tube. The child is not intubated. I'm operating on this side. The child is just sedated. And you see now the child is asleep but completely awake. There is no tube and I'm drilling. So this is where our anesthesia team has to be given due credit. Without them doing these kind of awake surgeries is impossible, because you see the analgesia is so perfect that child is not even wincing when her skull is being drained. And then this, now I have removed the epileptic lesion from her right side, and I'm very, very keen to see whether she's moving the left side. So remember, her brain is open on the opposite side. We are trying to test if she's moving. We are trying to see if she's moving the left side of her body, because we have done a right-sided surgery. That's me shouting almost excitedly because I'm a little impatient to see if the hand is moving or not. This tells me that I have not damaged any part of the right side of the brain that I should not have. This is the gold standard for intraoperative monitoring. And these awake craniotomies, remember, even adults can freak out at the idea of an awake craniotomy. So we have a team, and this is one of our neuropsychologists standing there. We have a team who counsels them, takes them to OT, gives them a complete tour of the OT so that they don't freak out or get scared in OT. And we also tell them all the tests that we are going to do whilst their brain is open. So, this needs a big team, but awake craniotomy is a standard. Difficult in children because many children might not cooperate. So generally done only after 12 or 13 years of age, but it is done. Now, this is stereotactic surgery. Now, this is a stereotactic frame where we are putting brain electrodes into the brain. And then the neurologist or the epileptologist records intracranial EEG, meaning each of this electrode has 10 to 16 contacts. So we have around 12 to 15 electrodes. So we have around 200 electrodes recording EEG. And then from those EEG interpretations, the neurologist and I will then decide if a certain area of the brain is spiking and whether that can be removed. So this is again stereotactic surgery, which is modern neurosurgery and very, very critical for epilepsy. And this was a 13-year-old boy in whom we had done this stereotactic surgery. And believe me, then he stays in the video EEG room for almost 1 week with these electrodes inside. The neurologist, the epileptologist tests him, produces seizures, gives current through each of these electrodes, and then studies the whole epilepsy. And then I remove it. And then in a second stage, we go and operate. Finally, I've almost come to the last topic of my talk, movement disorders. Now, this was a 7.5-year-old boy. I'll directly go. Look at the video of the dystonia. He was okay till almost 6.5 years of age when there was a sudden decline. You see, he's so dystonic, he almost lost all his motor milestones. He's practically, at times he would even get opistotonic difficulty. He was dyskinetic and dystonic practically the whole day. So he lost weight. See, he's almost become, bones, all skin and bones. And obviously difficulty in eating and could not go to school anymore. But his cognition was well preserved. There were thankfully no sucking and swallowing difficulties yet. But, this was the severe manifestation with which he came to us. Now, when this was there, all the investigations that we routinely do was normal. The MRI brain was normal as well. I'm sure you in your clinic see a lot of dystonic CP. That dystonia is secondary dystonia, which is secondary to some sort of brain injury. This was primary dystonia. And then when we investigated, we found a KMT2B mutation, which is actually responsible for this dystonia. So this is primary or genetic dystonia. Our case was a little atypical because there was very rapid progression. Almost within 6 months, he became bedbound from being completely normal. But like you see, these dystonias, KMT2B dystonias, start with lower limb dystonia and they move upwards to involve the cervical, laryngeal, and cranial dystonia. If you do not intervene, this child eventually will die and succumb. This is where we at our center do deep brain stimulation. So we did deep brain stimulation for this child, and this is our movement disorder specialist, Dr. Anaita. This was this child at 2 months post deep brain stimulation. Look at the remarkable improvement in this child. 2 months of deep brain stimulation. This is him at 3 months when he now, of course, he needs extensive therapy. He has, he was almost close to subluxating his hip. So physiotherapy was aggressive, but he started going to school. In fact, I saw him yesterday in my OPD. He definitely is having issues which are persistent, but this is the magic that deep brain stimulation can do, especially in well-selected cases. So I think this was my last slide. Very briefly, I know I've rushed through all the slides, but the intention of the presentation was to try and tell that modern neurosurgery has progressed, and pediatric neurosurgery, so to say, has become a very specialized branch. And with all the modern infrastructure, with a team where the neurosurgeon is working with specialists who understand the disease, and at a hospital where perioperative and intraoperative care can be taken, good outcomes or favorable outcomes are possible for many of the children, like in the cases that I have shown. Thank you very much.
Thank you, Dr. Saurav. We learned a lot.
Thank you.
Fantastic presentation, Manohar. I have some questions. Can I go ahead?
Yes, please.
Yeah, Dr. Saurav, you said that
Yes.
we should not call them as meningomyelocele and call them as specific names. So I wanted to know whether this is a clinical diagnosis or whether we should do it after an MRI.
So, like I said, broadly, it would be safe to call meningomyelocele as open neural tube defects. Everything else, where you see a skin or a skin-like cover, as closed neural tube defects. Okay. So clinically, you call is open and closed. The specific diagnosis will happen only after MRI.
One more question is, what is the correct age? Like we may not see at a year of age or something classical open neural tube. We may see just a dermal patch or a dermal sinus. What is the correct age to do an MRI?
Oh, as soon as you see the patient. So only if the patient is if the patient has a closed, so I will reframe what I've said. If the patient has a closed neural tube defect and we are in no urgency for surgery, given that the child is preserved well, then the earliest surgery can be done around 3 to 4 months of age. Oh. So therefore, Yes. So therefore, you can, because if the child starts developing a deficit, there is no point waiting till 6 months or 9 months, because till then the nerves will be stressed even more. So the earliest surgery is around 3 months. Most surgeries are done around 6 months of age.
So now
So
suppose I see a dimple or a dermal sinus, then I immediately ask, suppose
no.
this
So if the child is just 1 month old, you can just counsel the family that he will need investigations, but now is not the time to investigate, because even if it is, we don't really need to rush into surgery at 1 month. But if the child is around 3-4 months of age, then you can do an MRI, and then maybe we can plan surgery in the next 1 or 2 months, because the MRI is not really going to change. But if the child is 6 months or above, then you can directly do the scan the moment you see them in your clinic.
very nice, because we used to wait for a year of age to do an MRI.
No, safe surgery can be done as young as 3 months, like I said, even for lipomas,
Okay. And you also showed us that Cruzon's late
Yes.
presentation. So you all just did that distraction.
No. So I didn't show all the, like I said, it was for the delayed presentation Cruzon's, because his brain development growth is over. So distraction is done to give volume. But this delayed one that I showed was 7-8 years of age. So his brain growth was over. So now he didn't need volume. So
Cosmetic.
now we are planning, yeah. So we're planning a frontoorbital advancement to bring his forehead forward to treat the proptosis. He may need facial surgery depending on airway issues as he progresses. So a syndromic craniosynostosis child has to be on the follow-up of a craniofacial team at least till 18 years of age, because they can get spikes of raised ICP and they can get multiple issues till 18 years of age. So all craniofacial centers across the world keep these children on follow-up, at least an annual follow-up with an ophthalmology and imaging or sleep studies or anything else only if necessary. So it's not a one-stop surgery where you do a surgery and leave the child, at least the syndromic ones.
And what is
No,
proton
please.
radiotherapy?
Yes. So
Because I
proton,
had
yes.
a child of ependymoma, which was operated
Correct.
at SRCC, but by another surgeon.
Yeah, I know. I know of that case. I know of that case, madam. So proton beam therapy is, I'm not a radiation oncologist, but I'll just give you basic knowledge. So there are two forms. The traditional form of therapy is photon beam therapy. In photon beam therapy, what happens is that there is a beam that comes, it hits the target, but then it spreads a lot. So it causes more side effects. Proton beam, so this is called the exit dose, meaning the spread. Proton beam therapy is a focused therapy where the
Like
exit
laser.
dose is limited. So proton beam therapy causes lesser side effects. The only problem is that India, in fact, we are very lucky. We have two proton beam centers, one in Tata, the other in Chennai. Of course, the cost is almost double in Chennai because it's Apollo. In Tata and Kharghar, the proton beam therapy is around 15 lakhs of cost. But in countries like Australia, they don't yet have a proton beam therapy.
Wow.
So that means we are lucky. Our neuro-oncology team, we work very closely. In fact, this child is going for proton beam therapy as well. So I think the overall safety margin is good. Side effects are less, and if long-term effects, at least up till now, in many tumors have been proven good. But of course, it's a new technology, so we will need long-term follow-up to see what's the good control and other things. But it's definitely very well tolerated. That's the difference between proton and photon.
And one last question
Yes,
is,
absolutely.
I thought that deep brain stimulation was a medical procedure. It's a surgical procedure?
Oh, yes. Deep brain. So again, so deep brain stimulation is a complete. So it's a combi. So again, like epilepsy surgery, it is a surgical procedure for a problem. You put electrodes into certain targets in the brain. So like in this children, I had put two electrodes. In this child, I put two electrodes in a certain nucleus called the globus pallidus interna, the GPI. So we put two electrodes in that nucleus. Post surgery, we have a tab which connects through Bluetooth technology to those. So there is a battery in the chest, and then there are electrodes going to the brain. So you then connect to that battery and try to modulate the electrodes and the current delivered to the brain. That is done on an OPD basis, but the implantation is an absolute surgical stereotactic procedure.
Because I think it's also done for mental disorders, mental illnesses.
So the most common indication for deep brain stimulation is in the adult world for Parkinson's.
Yes.
Following which dystonias, like I showed in this case, this was of course pediatric. It is done slightly less commonly because of multiple technical problems, but we have done 3 deep brain stimulations till now. All children are doing well. Apart from that, you're right. They are also done in obsessive compulsive disorders, OCDs. So these are the ones which are commonly used nowadays, the common indications. But yes, there are certain psychosis and other things where DBS has been tried. DBS is also done for epilepsy.
Is also good for
Epilepsy.
epilepsy.
Yes.
I'm done with my questions. Thank you so much, Dr.
Thank you.
Saurabh. It was a
Thank you,
wonderful
Dr. Gopal.
presentation.
Thank you. Thank you.
Yeah. You want to go on, Manohar? I think Manohar has it's
Manohar
frozen.
is not.
Manohar?
Yes, yes, sir is
Blame
there.
that.
Manohar, yeah, our
Go.
next speaker. And you want to thank our earlier speaker?
Dr. Sushma Ade. She is assistant professor in pediatrics, PGIMS, Navi Mumbai. Am I audible, madam?
Yeah, your voice is breaking though.
Madam, here is the range problem is going on. That's why.
Yeah.
Dr. Sushma will talk on the topic of
But
a unique
where
journey of
Dr. Sushma
thalassemia.
has joined? Pallavi, has Dr. Sushma joined?
No, I cannot see her email.
Manohar, she has
like
not
that.
joined.
Okay.
Even
Then
advisor is
we
not
will
there.
go to the next speaker, Dr. Samir Dalwai, sir.
Dr. Samir has also not joined.
Manohar,
Then
you also,
are
Manohar, you
only
please
one.
also thank the previous speaker.
Yeah, please thank Dr. Saurabh.
Yeah.
Thank you so much, Dr. That
I think your voice is not very
theory
clear.
of
That's all right. But no, thanks. Thanks for having me.
Yeah.
It is wonderful to be with
Yeah,
all of you.
thank you, Saurabh. And we were very impressed with your posterior fossa tumor who did so well.
Yeah.
You know, and that spinal tumor, that congenital tumor
Yeah.
3 years later. So thank you very much for that presentation. We always feel CNS tumors of babies have, hopeless cases. But you have shown us so much hope. And you have so far only presented 5 of the conditions that which you do.
Yeah, I had to be very quick. I'm sorry for
And
that,
you
but
really kept to time and answered all our questions very,
thank
very
you.
in details. Thank you so much, Dr.
Thank you very much.
Saurav, and
Thanks for
hope
having
to
me.
see you
Yeah,
again on our webinars.
absolutely. Thank you. Bye.
Yeah.
Bye.
Thank you so much. I don't know if our next 2 speakers, Dr. Samir Dalwai and now I think even Manohar has disappeared. So, shall we, Archana?
Anjali,
Madam, we can go ahead.
Manohar? Yeah.
Madam.
Yeah, so
Yes.
yeah. So should we just take Palghar epidemiology first and then wait for Samir? Will you call up Samir and Sandhya?
yes, Anjali,
No,
I think
madam,
we should
madam.
go ahead.
Huh?
You go ahead with epidemiology.
Yeah.
So that we don't waste time. And then
Yeah.
in the meantime, if they join, we can join them.
All right. So I wanted to specifically first talk about, the great scare that is going on about our COVID-19 flare-up. And I had the good fortune of speaking to the pulmonology head of JJ Hospital. And I think we should always have one, central place where we can get reports from PCR or virological studies so that we know what is happening. And the pulmonology head, Dr. Sushant Mane, said that they have not seen any COVID-19 so far. And their hospitalizations, in fact, 2 patients who got hospitalized and were ventilated for a respiratory infection were 2 para-influenza viruses. They have also seen influenza virus, but they have not seen any adenovirus. And so I think even in our area, there is no scare and there is no notification for COVID-19. So I don't know what is the experience of others. So people who are from Nagpur and from other places, please let us know. Dr. Suryakant, there is a lot that is being, yeah, please, Manohar, your hand is raised. Manu. Yeah, Suryakant.
Video.
See,
I'm not able to.
yesterday only people from our area met our district collector, and she has actually one hospital in Boisar, which is, I think, was to be transferred to the original masters. Like Tima Hospital in Boisar is a government hospital. Tima is owning that, and they have asked for that give it back to them. But I think our district collector has said that in view of COVID scare, I think we will take back the hospital from the Tima management, and it is maybe designated a Tima COVID center for Boisar and Palghar Taluka.
But as yet, there are no cases.
Cases, I don't know. We are not actually
Doing
doing any
PCR.
test. We are not doing tests. There are so many URTI there. We don't ask them. I have made a practice since COVID that I wear a mask, and I ask those who come in my cabin, they have to wear a mask. That is my policy, and I tell them government will not teach you now again and again the do's and don'ts of the COVID, because they have given 3 years exclusive training on COVID. So it is your duty. I tell them, if you don't want to wear, you go to other doctor. We have to be little strict.
Firm.
Especially medical reps, we have to tell them again, because they are moving around in our all OPDs. So
Good
that
idea.
I think we can, all our consultants, they can ask, at least patient, those are visiting us, ask them to wear a mask.
Yeah. And hand sanitization,
That
distance.
other things we have to do, hand
Yeah,
sanitization.
yes. And distance, and also social distancing and avoiding crowded places. But
Yeah.
we have forgotten all that, and we have gone back to our old ways of parties and get-togethers and things like that. So that was some of the things that we were seeing. And anyone seeing GBS? Because I think there was a scare of GBS from Pune some time back. And I don't know if anyone here is seeing GBS. We are seeing a lot of, although the OPD has slackened due to the holiday season, we are seeing a lot of respiratory infections. Of course, it must be flu and para-influ. So anybody with, I think Hemant has raised his hand, or Archana. Archana, you'd like to say something about flu, para-flu? And I think only yesterday Archana had put up about typhoid.
A case of typhoid fever.
Yeah.
Am I audible?
Yes,
Yes,
Archana.
yes, ma'am.
Yeah. So we
And
had a case
Anjali,
of culture
I
positive
also had
typhoid
two.
fever.
Let Archana finish.
Yeah,
Then
yeah,
you can
finish.
Yeah,
comment.
we had a case of culture positive typhoid fever. So I put the sensitivity pattern on the group for everyone. They are still sensitive to cefixime and azithromycin. I did admit this child for about 5 days and have sent him on oral medicines. And he's doing well. The baby is doing well.
What did you give when you hospitalized?
Ceftriaxone. I gave him ceftriaxone, 100 per kg, and then he was febrile for 2 days, so we discharged him, and he's on oral cefixime 20 milligram per kg. So I didn't have to add azithromycin because he responded to ceftriaxone.
Yeah, and even Tanu Singhal had told us that there is no need to add a second. We have to wait
Yeah.
for a long time for defervescence.
Yes.
Yes, Suryakant, you were saying
I
something.
also had two patients of typhoid, those proven with the Salmonella typhi culture positivity. So I think if we do regularly, we may get the cultures positive. It is we don't do, and I think Dr. Ganpati has come to Boisar 2 months back, and he has said, don't do Vidal test because it confuses you. So he has said a cross on Vidal test. If you want to do blood culture, otherwise don't do any case. Or he has suggested that if you are suspecting typhoid in first few days, then he has said that you can go ahead for ultrasonography if hepatosplenomegaly and liver involvement, and with GI symptoms that will go with a fever, high fever, that will go in more favor of typhoid instead of doing Vidal test. That was his take on that lecture, and he said, insisted on that, give proper treatment as madam has said, and azithromycin has to be reserved, not to be given immediately.
Yeah, in fact, I think I don't know how many of you all are watching the Dr. Amdekar's Steer channel, and there are many YouTube and early diagnosis of fever. Dr. Rajesh Chokhani spoke. that by day 3, if the fever is still running very high and there are no signs of either cough, cold, urinary infection, or loose motions or vomiting, then suspect typhoid in our kind of setup and think early about typhoid and start treatment. And of course, after sending blood culture. So I think blood culture is the gold standard, and we should stick by that. There are many people who still do Vidal test in the first week also. So forget about not doing, they do it in the first week. So I think we should all refrain from doing Vidal test and have a high index of suspicion. And I don't know, Archana, typhoid vaccine is being given in Virar, is it?
Typhoid vaccine is being given in Virar.
Yeah.
Yeah.
Of course, it's not. Yeah.
Although they don't give
Madam.
conjugate vaccine, they give polysaccharide vaccine.
What was the age of your patient?
3 years old.
My God. So
Yeah, and
young.
they used everything homemade, but he was fond of paneer butter masala, so they would buy paneer butter masala from outside to feed the baby because he was fond of that vegetable.
Yeah, Manohar was saying something. Yeah. Yeah, Suryakant.
One more thing, I think we should ask our pathologist friends. See, when we ask for specific investigation, they give patient because it is available, like a lot of now automated machines are available. They start giving all nonsense stuff, and which creates problem for us. If you ask for specific CBC, ASR or says, they will give you LFT along with that, dengue also, Vidal also. I think we have to stick to our ethics and ask the pathologist, don't do any test beyond what we have asked. Because then patient comes and start fighting with us. Sir, डेंग्यू थोडंसं पॉझिटिव्ह आहे, काय करायचं आता, हे प्लेटलेट खाली गेलेले आहेत, and they underline it, That creates a big problem to explain to the parents.
Yeah, Suryakant, Dr. Samir Dalba is online, and we have just, Samir.
Hi.
Yeah, Hemant. Yeah,
Continue.
Hemant.
Give me 5 minutes.
Suryakant.
More.
Yeah.
Give me 10 minutes more. Let Hemant sir speak.
Yeah.
हा एक मिनिट सूर्यकांत
Yes, बोला.
सूर्यकांत तुला शाळांसाठी टायफॉइड वॅक्सिन 700 रुपये अबाउट 800 रुपीज साठी पर स्कूल 50 डोजेस सॉर्ट ऑफ असं टायपार्टिसिव्हिजन मिळू शकतात.
हो नाही मी झायडसचं केलं होतं 400 वॅक्सिन ऑर्डर केल्या होत्या पण अनफॉर्च्युनेटली पेरेंट्स डोंट वॉन्ट टू टेक. आय हॅव स्पेसिफाईड दॅट at least 8, 9, 10 standard students should take typhoid vaccine because if they get typhoid, at least 2 months they are wasting. So I said that some amount will be paid by the school, at least you pay 350 or 400. That also response was very poor.
ऐक ना, एका शाळेमध्ये 50 म्हणशील तर टीचर लोकांना सांग ना त्यांच्या मुलांना द्यायला. म्हणजे
that is what is there on my agenda actually. My agenda is at least 9th and 8th standard students should be given typhoid vaccine. As you have pointed out in various your suggestions that typhoid should be given to each and every individual. Now for pediatric age group also 6 months. So I think each one.
शिवप्रकाश म्हणून मागच्या वर्षी शिवप्रकाश म्हणून IAP प्रेसिडेंटला उभे होते तामिळनाडू मधून. तर शिवप्रकाश जेव्हा MD करत होते ना त्याने 12वी आणि 11वीच्या 12,000 मुलांचा पूर्ण वर्षभराचा अभ्यास केला आणि त्यांना असं लक्षात आलं की जे लोक मागे पडले ते टायफॉइडमुळे 1 महिना घरी होते म्हणून मागे पडले. त्यामुळे तुम्ही एवढं छान काम करीत आहात. असं एक शाळांमध्ये सांगून बघा तुमच्या की टीचर्स
I will do that as soon as school
700-800
opens.
रुपयाला द्यायला राजी आहे 50 डोजेस पर स्कूल. त्यांचा सगळा स्टॉक वापरून घ्यायला पाहिजे आपण. थँक्यू समीर. सॉरी दरवेळा माझ्यामुळे तुझं
माझ्याकडे
या मनोहर. मनोहर तुझा व्हिडिओ बंद कर आणि ऑडिओ चालू ठेव. मनोहरचा मला वाटतं ऑडिओ व्हिडिओ दोन्ही गेले. So I think we'll carry on with the next. Samir, you're ready?
Anjali, you do the needful because
Yeah,
Manohar sir.
Dr. Samir Dalbai. He asked for 5 minutes. Dr. Samir? I think till Dr. Samir joins back, I want to talk about our conference, our endocrinology conference, which was so great, so awesome. We had such a wonderful faculty. Dr. Vaman Khadilkar, all the way from Pune, Dr. Shruti, and all the other faculty was so lovely. And we had so many takeaways, and the workshops were lovely. We have 15 charts. And, if we can chart even 2 or 3, that will be fantastic. But we've had a treat of a conference. And now it's a joy to mark every height and weight and, know what all has gone behind it. Yeah, Manohar, you can carry on and invite Dr. Samir Dalbai to speak.
Madam, here is a range problem since morning, madam.
Yeah,
So
to
intermittently,
video,
I may
Manohar.
not be able to connect.
Yeah, Manohar, can you put your video
Hello.
off? Yeah, Manohar, put your video off and just talk. Yeah.
Madam, here is a range problem since morning. I
Yeah.
want to discuss one case regarding typhoid. One
Yeah.
patient admitted at my hospital. He had
मनोहर तुझा आवाज गेला. हा, he had what? Manohar, we can't hear. We could not hear you.
madam, but
I don't know if anybody can hear him. Manohar, तुझा आवाज खूप break होतोय. We can't hear you. Archana, can you hear him? Archana? Manohar, I can't hear you.
We cannot hear him.
We cannot hear you, Manohar.
yes, because
मनोहर तुझा आवाज खूप ब्रेक होतोय.
madam,
Ma'am, Samir sir has joined.
Yeah, I know.
Samir Dalbai has joined.
But Samir, would you like to speak now? Samir? I think Samir is also not yet ready. मनोहर तुझं काहीच ऐकू आलं नाही.
Ma'am, he has
मॅडम रेंज प्रॉब्लेम असल्यामुळे सगळं होतं मॅडम.
Okay.
रेनी सीझन असल्यामुळे रेंज प्रॉब्लेम येतोय मॅडम. त्याच्यामुळे कोणच कनेक्ट करू शकत नाही.
Okay. Yeah, but we couldn't hear
That is the
anything about your case.
मनोहर सर
मॅडम
तुम्ही
रेंज प्रॉब्लेम.
व्हिडिओ परमनंट बंद करा मनोहर सर.
तुम्ही व्हिडिओ चालू करूच नका मनोहर. हा.
Then only we will be able to listen to you.
Am I audible?
Yes, you are audible, sir.
Yes.
हा मॅडम, जस्ट आपल्याला मीटिंग कंटिन्यू करायची की डिस्कशन कंटिन्यू करायचं मॅडम?
You just continue. Dr. Samir has not yet joined. Means he has joined, but he is not ready with his this. So please tell your case. You were just saying you had a case, but we couldn't hear anything.
मॅडम, एक माझ्याकडे एक पेशंट ऍडमिट होता ज्याचा ब्लड कल्चर पॉझिटिव्ह होता. But he had already received 2 doses of type 1 TCV.
Okay.
In 2017 and 2018, and the fever is lasted almost, and to the
Manoj, can you come into better range if you're on your mobile?
can get a salmonella typhi infection, and this is the third case, madam. This is third case of mine. ज्यांनी ऑलरेडी टाइप 1 TCV वॅक्सिन घेतलेत तरी सुद्धा ते टायफॉइड पॉझिटिव्ह आलेत.
Culture positive, na?
Culture positive, madam. Culture positive.
Yeah, so the thing with typhoid vaccine is that even if it's a polysaccharide vaccine, at the most it gives 75 to 80% coverage, seroprotection. And to really take care, if the bacterial load in the ingestion is very high, a patient can still get typhoid. So that is the thing, that if patients take typhoid vaccine and they think that they can, eat anyhow, that's not true. Unlike a viral vaccine, like measles, mumps, rubella, chickenpox can give us nearly 95% and above protection. A bacterial vaccine gives a little less protection, only 75 to 80%. So we still have to be careful and not eat out or eat only cooked food and drink, clean water. So typhoid can still occur if we have even taken 2 vaccines. So that is the case with Manohar, I'm sorry, I can't hear you. And can we request? Huh?
We recommend single only.
I'm sorry, I can't hear you at all, Manohar. Dr. Sameer Dalbhai? Sameer? Manohar, perhaps you can type in the
Hello, Joshi ma'am, are you there? I think Anjali ma'am has left from the meeting. No. Anjali ma'am is back. Okay. Yes, ma'am. No, sir, your voice is very breaking. We cannot hear you.
Has Dr. Sameer joined?
Ma'am, he had joined, but
He's not yet online.
Yes.
Okay. मनोहरचा आवाज अजून ऐकू येत नाहीये ना?
मॅडम रेंजचा प्रॉब्लेम आहे, मॉर्निंग पासून त्याच्यामुळे सगळे
That's okay. I think, Manohar, can you please call up Dr. Sameer and ask him to start? Yeah, in the meantime, can you call up Dr. Sameer Dalbhai?
Madam, I will try to contact him right now.
Yeah. In the meantime, Dr. Sameer, I think he has put something in the chat. Can anyone read the chat? Archana? I got logged out of the laptop and I'm on the mobile now, so I can't see the earlier chat. Archana?
मॅम कोणाचं चॅट हवंय तुम्हाला?
Dr. Sameer Dalbhai, look at the
नाही,
chat.
त्यांचं नाहीये, त्यांचं काही चॅट नाही.
All right, okay. So just to ask others on the chat, on the
Anjali,
webinar.
there's nothing on the chat by Sameer.
Okay,
Yes, yes, ma'am. I just checked.
Okay.
There is nothing.
Yeah. Dr. Rajendra, are you seeing many cases of COVID in your vicinity? You're on mute. You're on mute, Dr. Rajendra.
Yes, madam. I'm seeing many patients who are having cough, cold, fever, and similar symptoms of body ache. Like one of the twins' pregnancy is sitting. Hi, madam. Hi. And she's having severe body aches, of cold. Now she's improving, but exactly we are not getting the case. But maybe they are there internally. We'll have to see. Presently, the things are there going on.
Yeah, so I think they had said that we are going to have it as a endemic virus, just like the flu virus, and not like the epidemic or the pandemic we saw last time. So seeing an occasional case, I don't think we should panic or worry that this is, like what we saw 5 years ago. So that is the thing.
Yes, madam.
And we are not even doing PCR. So
Yeah.
I think there is no reason to panic really.
Yes.
Yeah. Anyone else seeing? Yeah. Yeah, Dr. Rajendra.
WhatsApp call is there,
Yeah. Okay. And also, I wanted to say that we are having our next sickle cell OPD at Dahanu on the 14th of June. That's a Saturday. So please, if anyone has any cases of suspected sickle, then do refer to Dahanu Sub-District Hospital. Yeah, Samir. Welcome.
Hi, namaskar. Good afternoon.
Namaskar.
Everybody.
Good afternoon. Yeah. Go on, Samir.
Shall I start?
Yeah, Manohar, you want to introduce Dr. Samir? He doesn't need an introduction, but yet.
Thank you, Acharya.
Dr. Samir Dalwai is a dynamic and cheering personality. He is a developmental behavioral pediatrician who has completed his MBA from Medical Hospital, Mumbai. He is a recipient of Government of India's Rajiv Gandhi Seva Award for the Dr. Dalwai sir is founder and director of New Horizon Child Development Centers at Mumbai, that is based in the Goregaon, Vasi, and at multiple places. He is a founder member of that New Horizon Institute and Research Center. He is a IIP postgraduate fellowship in pediatric developmental pediatrics plus postgraduate diploma in special education and had done certificate courses in psychology in affiliation with the Tata Institute of Social Sciences. Please start, sir. Dr. Samir sir, there is a brief introduction to you. आपका और भी बहुत सारे जो है जो बुक्स है आर्टिकल्स है वो सब लोगों को ऑलमोस्ट मालूम है. So please kindly start your session.
Thank you. Namaskar. Can you all hear me?
Yes, sir. Yes, sir.
Yeah,
You are audible.
My
And PPT is
respected,
visible. Thank you.
respected Dr. Archana Madam, Hemant sir, Dr. Jayashree Madam, I think she is not able to attend today, but Dr. Alka Badbade Madam, my dear Dr. Anjali Madam, dear Dr. Suryakant ji, Manohar Bhai for such a kind introduction. All my dear friends and colleagues from Palghar and everybody else close by. Thank you so much for this opportunity to present for all of you. And the topic that we are going to talk about is very different today. तर आता का हा टॉपिक कारण आता आपण म्हणतो नेहमी की the normal development that has been taught to us itself was not very well done. And त्याच्यातनं abnormal development. So we are all confused about autism, ADHD. We learn bits and pieces. We try to memorize some things that we hear in some conferences. But there are so many confusions that we have. There are two major confusions. One confusion is why is it that when all of us know that the mobile is bad for children, why is it that we are still not able to get rid of the mobile from the children are not able to get away from the mobile. And the second thing that we need to know is why is it that today we are seeing more kinds of challenges with behavior and sometimes there is not even a diagnosis. We send for evaluation but we don't get a diagnosis. What are the two reasons? What are the reasons for these two problems? Is what we'll try to understand today. आणि याच्यात माझं ब्रीद वाक्य, as always, which I say, is human engagement powers learning. All of us are engaging today to learn from each other, but it's very relevant for children. So what is generation beta? So you have the millennials, then you have the generation next, then you have the generation alpha, but those born after 2025 from January, so who are already 6 months old, 5 months old, are part of generation beta. Why is it important to study generation beta? Because humans have evolved over the last 6 million years, but every child who was born in a world that was a little bit like the earlier world or the earlier generation. But these children will come into a world which is completely unlike anything even their parents have witnessed before. And that's why only in a span of, say, 25, 30 years, we have had already 3 generations. Earlier, the generation gap used to happen at 40 years, 50 years. Now it's happening at 10 years. And you can see now it's 15 years for next. 2 neurons shaking hands and exchanging information. Like 2 people meet at the water cooler or in the canteen and exchange gossip. And that's how the news spreads all over the class. Who is going around with whom. So that gossip is exactly what information one neuron is sending to the other. And that's how the brain transfers and learns information. And that's why when these neurons connect to each other, everything that has to do with cognition, with understanding, with behavior, with speech, with learning gets better and better when more and more neurons shake hands, just like society does better when we all learn to live with each other. But if you see here, it's very clear that the maximum potential for learning is in the first 1,000 days, but not thereafter so much. Hey, Gupit, काय की का first 1,000 days is so important, but not the others are so much? Why? Is it only because of the density of the neurons and the synaptogenesis that the Western world wants us to know? Or is it something else? And that something else is what we will look into today. But before we go ahead to the next generation, we have to look at all the past generations. And you will be surprised to know that what you see on the right side of your screen, Anjali madam, can you tell me ह्याच्यातलं काय striking आहे?
Which one? Above one.
Beg your pardon?
Which one? That one on top you're saying?
The one on top, sorry.
So a man from quadruped has become biped.
Correct. So what madam has talked about evolution of mankind over 6 million years, this is same almost seen in every child during his lifetime. Even the child is a quadruped to begin with, madam.
Yes.
And then he becomes biped, etc., etc. So whatever has happened in the last 6 million years in human evolution is recorded in its genes, and those genes are transmitted. And though the new gene codes for a better brain and the child is born with a better brain, yet the child has to go through all these stages. Am I right?
Yes.
What is very important to understand is then what is the difference overall between humans and animals? The biggest difference is not just in the standing or the walking. The biggest difference is in the cognition. And what is the difference in the cognition? It is that animals are based on the fight or flight binary. Binary म्हणजे alternative. दोनच alternative आहे. लढो या भाग जाओ. Which is what we roughly call the autonomic nervous system. Which is what animals live on. तो एक मांजर आली समोर तुम्ही चिमटा काढला तर ते पटकन तुम्हाला मारेल तरी किंवा पळून तरी जाईल. But because humans evolved, they developed the prefrontal cortex. And what are the 4 major things that the prefrontal cortex taught you? I know all of you are my seniors. मेरी ऐसी कोई ये नहीं कि मैं आपको कुछ सिखाऊं, हैसियत नहीं है. मगर I will still request you to please write down these 4 functions. Because no textbook has ever put this down. And nobody will teach us over the next, after 10 years, we'll realize the importance of this. What are these 4 higher functions? Can people in the audience tell me what each one means? Bola.
Delaying gratification.
What is delaying gratification?
Yeah, means postponing enjoying or celebrating or getting something. Yeah, a reward.
Can you give me an example?
So you want to eat a chocolate and you say, no, I'll first watch this webinar and then eat a chocolate.
Excellent. Very good. Everybody just show thumbs up if you agree. If you don't agree, then you can interrupt and ask. Second point, what is rational thought? Rationality. आंबेडकर सरांचे सर्व शिष्य आहेत तिथे.
Yeah, I think Archana and all must be on their way to Dr. Ambedkar's class. Rational thought means something that is logical. So,
Correct.
yeah, you say it's, it's going to rain. That's rational because it's so cloudy.
Correct.
Yeah.
Now, if it's going to rain, should I stay indoors or should I go out? Is binary. Even an animal can decide, or an unintelligent man can take this decision. But बाहेर जायची मला गरज आहे का? माझ्यासाठी डॉक्टर अंजली थांबलेत, मला जावंच लागेल. मग जाताना मी काय करू? मी छत्री घेऊ की रेनकोट घेऊ? किती पाणी असेल वाटेत? गमबूट घालू की साधे चपला घालू? हा जो विचार चालत असतो, ऍज कम्पेअर्ड टू की जाऊ की नको जाऊ, हा जो मध्ये विचार चालतो, दॅट इज रॅशनॅलिटी. यू आर थिंकिंग मल्टिपल पार्ट्स. द एनिमल ब्रेन कॅनॉट डू दॅट. What is the third point? And somebody other than Dr. Anjali to talk. Communication, which animals are not able to do as much as humans because of prefrontal cortex. Bola.
Manohar, tu bol. Suryakant can speak.
Is it development of language in animals which has led for our development and we have become superior in animal kingdom, which is a way of communication.
करेक्ट. तर जो आपला रॅशनल थॉट आहे, जो आपण विचार केलाय, तो मला डॉक्टर अंजलीला आपण सांगायला पाहिजे ना, की मी येऊ शकत नाही किंवा मी येऊ शकतो, काय करायचं, कुठे तुम्ही, दॅट हॅव टू बी एबल टू कम्युनिकेट. And finally, after all that, the most important is the last thought. And the last ability, hello, are you able to see the screen?
Yeah.
The last ability is the number fourth one, which I definitely want all of you to put your mind to think and tell me what it is. And give me an example of that.
Manohar, go ahead. Come on. Bol Manohar.
As a leader, you can think of your group and you can guide them by thinking smarter than the.
Correct. So that's an example असं आहे की 5 million years back, we were no match for the tiger. Even now, we cannot kill a tiger with our own hand. So what we do, we tell 10 people, you come from this side आणि आवाज करा. 10 people come from this side, आवाज करा. आपण त्या हत्तीला इकडे म्हणजे घाबरून त्याला एज ऑफ द क्लिफ पर्यंत नेऊया, तिथून तो पडेल खाली घाबरून, मग त्याला आपण मारूया. तर हे जे 20 लोकांनी एकत्र मिळून जे करायचं असतं, ही ॲबिलिटी प्राण्यात नसते आणि ही फ्रंटल कॉर्टेक्समुळे येते, की आपण सर्वांनी एकत्र विचार करून काय ऍक्टिव्हिटी केली पाहिजे. This is the most vital ability of humans. And from this came the concept of tribes or villages or cities or nations or teams. 11 people have to think we are representing one team, other 11 have to think we are representing other team, and then we fight against each other. The concept of nationhood, of countries, the concept of ideologies, communism versus capitalism or socialism, the concept of religion, caste, all of it is ideas which we are able to convince other people की हे खरं आहे की नाही आहे. आणि असं जर एकत्र विचार केल्यावर जे होतं ते आपण जगात बघत असतो. ह्या चारही गोष्टी प्री फ्रंटल कॉर्टेक्स शिवाय करता येत नाही. सो प्लीज रिमेंबर दिस. पण ह्या चारही गोष्टी घेऊन झालं काय की माणसं कम्युनिटीमध्ये मुलं जन्माला यायला लागली आणि ह्या गोष्टी शिकण्यासाठी कम्युनिटी लागायची. कारण डिले इन ग्रॅटिफिकेशन, जर मूल जन्माला आलं आणि त्याला जंगलात सोडलं तर त्याला डिले इन ग्रॅटिफिकेशन कळेल का अंजली मॅडम?
नाही.
त्याला रॅशनल थॉट येईल का?
नाही. इट्स जस्ट फाइट ऑर फ्लाइट.
करेक्ट. सो दो द चाइल्ड इज बॉर्न विथ द जीन्स, हे बघा इथे लिहिलंय, जीन्स वर्कड ऑन द ब्रेन. दो द चाइल्ड इज बॉर्न विथ द अनॅटॉमिकल प्रीफ्रंटल कॉर्टेक्स, unless that prefrontal cortex is exposed to nurturing care in the large families like it happened in the last 6 million years, the brain is not able to express those genes and the brain is not able to develop these higher functions of, Anjali madam,
Rational thought
and
delay gratification,
and
communication, and ability to think as for the large group.
So earlier, because children were born in communities, this is how schools used to be. The book is thrown to the side. It is human engagement that was powering the learning. But today, the child wakes up at 6:30 in the morning. 7 वाजता तिकडे बसचा हॉर्न वाजतोय. अर्ध्या तासात त्या मुलाला जागवायचं आहे, त्याचे ब्रश करायचं आहे, त्याचे तोंड धुवायचं आहे, त्याला परसाकडे जायचं आहे, त्याला आंघोळ घालायची आहे, कपडे घालायचे आहे, ब्रेकफास्ट द्यायचे आहेत आणि नंतर दप्तर पण द्यायचं. आणि त्या बसमध्ये घालवता असताना जर मूल म्हणाला की काल माझं आणि मनोहरचं भांडण झालं कारण मनोहरने माझी पेन्सिल घेतली, तर आयडियली आईला म्हणायला पाहिजे, अरे तो मनोहर तुझा मित्र आहे ना, त्याने पेन्सिल घेतली म्हणून काय झालं, त्याला काल राहिली असेल पेन्सिल त्याची, तिची आई आजारी असेल, तिने पेन्सिल दिली नाही, अरे त्यांनी काल घेतली तर आज तुला पेन्सिल परत देईल, त्याच्यात एवढं काय तू हे घेतोस, तो तुझा मित्र आहे, त्याच्या बरोबरच तुला जगायचं आहे, त्याच्या बरोबर काम करायचं आहे. आता ह्याच्यात आई काय डिस्प्ले करते, शी इज टीचिंग द चाइल्ड डिलेड ग्रॅटिफिकेशन. She is herself being able to use rational thinking and show rational thinking. She is able to demonstrate communication and she is teaching Manohar how to think of in the larger interest of the group. बट आता 7:30 आणि 7च्या मध्ये एवढ्या वेळात ह्या सर्व गोष्टी करत असताना जर मी म्हणालो की आई मनोहरने माझी पेन्सिल घेतली, तर सध्याची आई काय बोलेल,
गप्पा बस आणि जा तू, आल्यावर बघू.
एक्झॅक्टली. आजपासून मनोहरशी बोलूच नको किंवा गप्प बस. ह्याच्यात रॅशनल थिंकिंग शिकता येईल का मनोहरला, म्हणजे समीरला? याच्यात कम्युनिकेशन शिकता येईल का? आणि मनोहर बरोबर एकत्र कसं राहायचं, जुळवून घ्यायचं, ह्या गोष्टी घडतील का? तेव्हा बऱ्याच गोष्टी ज्या आपल्याला हेमंत आणि अर्चना जोशी मॅडम सांगत होत्या, त्याच्या पाठचे थोडंसं सायंटिफिक लॉजिक आहे की इफ देर इज नो टाइम फॉर नर्चरिंग केअर and if the parents or the joint family is not there to do nurturing care, automatically the child will lapse back into the same binary of the earlier thing, that is yes or no, good or evil, strong or weak, and that is how the child will start being back into the same binary. And what is happening, which all of us have to now very carefully understand, is parenting is suffering from a lack of time for nurturing. Worst, if you don't have your own relatives, you are from Chiplun but your parents have settled in Mumbai like mine, at least we had बाजूची काकी, शेजारची मावशी, शेजारची आत्या. Today nobody has time for all of them, and today everybody wants their children to be on screen, but there is no neighborhood. Please take a screenshot of this article, download it from the net. It is on the Outlook magazine which I had written. There is no शेजार. आणि शेजार नसल्यामुळे, पेरेंटिंगना वेळ नसल्यामुळे, काकी सख्खी काकी मावशी आत्या मामी नानी नसल्यामुळे कुठेही मुलांचं नर्चरिंग होत नाही. आणि म्हणून तुम्ही प्रीफ्रंटल कॉर्टेक्स परफेक्टली जेनेटिकली डिलाइव्ड असेल, सर्व त्याच्यात न्यूरॉन्स असले तरी आपण वागतो मोरॉन सारखे, कारण देर इज लॅक ऑफ प्रॅक्टिस फॉर द चाइल्ड that is never involved in these situations to kindle the genes to learn all these things. And now we complain की आजकाल मुलांना एम्पथीच नाही. मी सांगितलं तुझ्या मामांचा ऍक्सिडेंट झाला, झालं का, मग ठीक आहे ना हॉस्पिटलला, अरे असं बोलतोस का मामांच्या बद्दल? अरे घरी आत्या आले, जरा बाहेर येऊन आत्याला जरा हाक तरी मार. कशाला मी हाक मारून काय करणार आहे? मुलांना ना आजकाल एम्पतीच नाही. अरे एम्पती कुठून? IAPच्या मॉड्यूलमधून येते का? की कुठल्या शाळेच्या टेक्स्टबुकमधून येते का? ती ह्या सिच्युएशनमधून येते. अनफॉर्च्युनेटली पालकांना वाटत असतं की आम्हाला हायफाय शाळा, डॉक्टर सूर्यकांतजी मी कुठल्या शाळेत टाकू? IB करिक्युलमला टाकू, IGCSEला टाकू, CBSEला विचारतात की नाही सूर्यकांत भाई? कुठल्याही बोर्डात टाकलं तरी तिकडे जे काकी मावशी आत्या मामीकडे सोशल मॅन्युअरिंग शिकायचं असतं, की ही काकी थोडीशी कुसकी आहे, हिला हे चालायचं नाही उद्धटपणा, इकडे जरा गप्प बसलं पाहिजे, किंवा हिच्या समोर आईस्क्रीम खाऊन चालायचं नाही, तिला आईस्क्रीम खाल्लेलं आवडत नाही. पण मावशीला चालतं, मावशीच्या घरी करू शकतो हे सर्व, पण तेवढ्यात ती कुसकी काकी आली तर जरा ते आईस्क्रीम लपवलं पाहिजे, ती जाईपर्यंत गप्प बसलं पाहिजे. ही शाळा शिकवते का तुम्हाला ह्या गोष्टी? नाही. तर शाळा काय शिकवते? 1+1 is 2. जर तुम्ही 2 म्हटलं तर यू आर करेक्ट, तुम्ही 3 म्हटलं तर यू आर रॉंग. सो आयदर यू आर राईट or you are wrong. If you give all right answers, you have passed. If you give wrong answers, you have failed. So pass or fail, promoted or retained. If you follow the orders of the school, you are a good boy. If you don't, you are a bad girl. Unfortunately, please understand, schools and academics are based on being judgmental. Because Newton's first law is Newton's first law. You cannot give the second law and get good marks. So academics is judgmental and binary. Schools are binary. And hence there is a very big regression that is going on among all of us. And this regression is we are going back 6 million years to the animal world, because all our children are now becoming emotional, anxious, शॉर्ट टर्म थिंकिंग, नॅरो माइंडेड, सेल्फ सर्व्हिंग. स्वतःचं काय, तू आता मनोहरशी बोलायचंच नाही, त्या दिवशी पेन्सिल घेतली संपली गोष्ट. अँड द रिअल विक्टिम्स ऑफ ऑल ऑफ दिस इज देर इज नो डेव्हलपमेंट ऑफ रिझनिंग or empathy or learning delayed gratification or ability to resist impulsive thinking. The children who are being born and developing in a binary world, भाईचारा का कुछ समझता है क्या कि भाईचारा क्या होता है? इक्वालिटी की मेरे पास 2 पेंसिल है, मनोहर के पास बेचारे के पास एक भी नहीं है, तो चल एक पेंसिल मनोहर को देता हूँ. सोशल कॉजेज, क्लास में 10 बच्चे हैं जिनके पास पेंसिल नहीं ले सकते, चलो हम उनके लिए कुछ करते हैं. मोरालिटी, एम्पति. आपको लगता है कोई बच्चे है आप में से कोई है जो बोलेगा आपके 4 साल के बच्चे को देख के आपको लगता है कि अगर इंडिया वापस से ब्रिटिश ने कैप्चर किया तो वो अपना घर का मोबाइल छोड़ के अंग्रेजों से लड़ने के लिए जाएगा? ऐसा किसी को डाउट है क्या माइंड में कि करेगा अपना बच्चा ऐसा? तुरुंगात जाईल का? काळ्या पाण्यावर जाईल का? का भारताला इंडिपेंडन्स मिळालं पाहिजे? बरं जाऊ दे, माझं वायफाय चालू आहे की नाही एवढं सांगा, आणि माझं मोबाईल चालतंय की नाही. सो व्हॉट इज द रिअल प्रॉब्लेम? ऑल चिल्ड्रन आर बिकमिंग शॉर्ट टेम्पर्ड, इल टेम्पर्ड, क्विक सडन रिस्पॉन्स चाहिए, नो एबिलिटी टू वेट एंड थिंक कि इसने ऐसा क्यों किया, कुछ नहीं. और मैचिज्मो सॉल्यूशंस, एकदम मैनली सिचुएशन चाहिए, अटैक करो, फाइट करो, मारामारी करके खत्म करो. How many of you have seen a movie called Superheroes of Malegaon? Has anybody seen Superheroes of Malegaon?
No, sir.
No. No, agree.
Recommended?
100% recommended. But it flopped within 2 days क्योंकि 2 दिन भी सिनेमा में कोई गया नहीं. So it flopped badly. The producer had a huge loss. How many of you have seen Animal? Animal,
Lots of people.
1,000 crores.
But it is a
Superheroes
very
of-
bad movie, sir. Very bad.
Superheroes of Malegaon talked about how if you are in Malegaon but you have Bollywood does not give you films, how you can make a replica of Bollywood in Malegaon by working together with the people that you have in Malegaon, by utilizing the resources you have, fighting against trouble, fraternity, equality, morality, and still doing what you have. And that picture failed because nobody wants to see these things today. But Animal, in which he says that I want to marry this girl because she has a big pelvis, so she will give birth to bigger children, which shows no rationality, totally misogynistic, macho kind of a thinking, no rational thinking. That movie is seen by people and makes 1,000 crores. This is the reason why such things are happening in the world. And that is why we are talking about reducing suicides. But the only thing that is reducing is the age at which children are committing suicide. And that is because the only prevention for suicide is developing resilience, which doesn't come because IIP chapter wants to make a module for pediatricians on decreasing suicides, or government of India should spend more budget on decreasing suicides. No, resilience comes when you know how to deal with that kuski kaki and that chilled out maushi, and how to control yourself till that kuski kaki is around, and then how you can behave when that kaki is not around. That is where your resilience develops. When you go to that Khadus kaki's house, but she makes great basundi, but you have to listen to 5-6 things that she tells you bad about yourself, ऐकून घ्यायचं, हजम करायचं आणि नंतर ती बासुंदी खायला मिळेल तोपर्यंत गप्प बसायचं. हे जोपर्यंत तुम्ही शिकत नाहीत काकीकडे किंवा मावशीकडे, you will not be able to really do anything to prevent suicides. So going ahead, in this world where all of these things are already there, this is how the human thinking has become. Now you bring in the digital world, and that's why it has only got worse. And that's why you cannot stop it easily, because the screen is not the problem. The screen is only the trigger in a gun which has already been loaded because of poor social engagement, poor nurturing care, nobody having time for their children, no joint families, no pados, no shezar, no neighborhoods, and everybody busy on their own mobiles, and that has decreased human engagement even further. So this is a project I'm working on. What happened in the last 25 years is a phenomenon which I call from cradle to classroom, where directly children were born, they didn't have relatives, they didn't have nurturing care, they didn't have Shizar, and that is what bypassed all the learning that you could get in the family and neighborhood. And now my theory is that actually autism is not caused by a bad gene or an abnormal gene. Autism is caused because the good genes are not getting the exposure to get activated. Just like all of us are born with a normal anatomical brain and two legs, can we walk at birth? Can you know? Can we even stand at birth? It takes bloody 1 year for us to be able to stand independently. It takes 3 years for us to clean our own potty or our own backside. Till
Yes.
3 years, your mother has to feed you, clean you, take care of you, clean your potty. If your mother is not around for the first 3 days after you are born, you will die. Just like physical ability requires nurturing care, more than that, mental ability, social thinking requires the nurturing care of kaki, maushi, atya, mami, ai, baba, kaki, and the pados. If you take this away, you are going to push children into the situation that they are unable to connect, and hence they do not develop empathy, resilience, they cannot understand relationships. And in the last 25 years, because family members were replaced by screens and the Shezar was replaced by schools, today in OPD Manor Bhai, you have children whose parents say that तो बसतच नाही, तो एका ठिकाणी थांबू शकत नाही, त्याला सारखं टीचरला हाक मारायचं असतं किंवा टीचरनी त्याच्याशी बोलली पाहिजे. ही थ्रोज टँट्रम्स, एकदा टीचर ओरडली तर शाळेत जायचंच नाही त्याला. But when you send them to a developmental pediatrician, the report comes no autism, no ADHD. अरे मग हे अरेच्या मग हे कसं चाललंय? ह्याचं कारण काय आहे? आता आपल्याला हे लक्षात यायला पाहिजे, पण गेल्या 25 वर्षात tremendous pace in which our perception of the world has changed. Human engagement is being sacrificed for digital engagement. Increasing digitalization in this field or in this ground of poor nurturing, with maybe some problems of genes, either bad genes or good genes not being kindled, with the poor social cognition and behavior which results from that, Americans have found a good business model to call it autism and then start giving medicines, tests, therapies, etc. etc. But the next 15 years is even more horrible and scary, because now you are not moving from cradle to classroom, you are directly going into the cloud. And what is the cloud? Away from reality. Anjali madam, when you go online today, if you see a video about the war, you have to wonder, हा खरा video है कि fake video है? And you will decide depending on which site it is. If it is an Indian site, you will say खरा video है. If it is a Pakistani site, you will say fake video है. But एवढं तुम्हाला कळतं ना. But if a 3-month-old child is shown artificial intelligence only, रियालिटी दाखवलीच नाही, तर खरी आई की डिजिटल आई हे कळणार कसं? आता तुम्ही जर इंस्टाग्रामवर गेलात अंजली मॅडम, तर तुम्हाला ऍड्स मिळतील. त्याच्यात मुलीला वाघावर बसवलेल्याचा पिक्चर आहे, 2 वर्षाच्या मुलीला. आणि तुम्हाला सांगितलं जातं की खाली ऍप डाउनलोड करा. तुमच्या मुलीचा असा पिक्चर आहे का तुमच्याकडे? अरे चा, तुम्ही मुलाला अब्यूज करताय, तुमच्या मुलीचा असा फोटो नाही? मग हा ऍप डाउनलोड करा, फक्त 1,500 रुपये. आणि त्याच्यात वाघावर बसलेली तुमची 2 वर्षाची मुलगी, सिंहावर बसलेली, हत्तीवर बसलेली, गाढवावर बसलेली, फ्रँकेनस्टाईनवर बसलेली सर्व चित्रपट तुम्ही AI ने डाउनलोड करू शकता. आणि मग तिचं पिक्चर बुक बनवा आणि तिला सकाळ संध्याकाळ दाखवत बसा. म्हणजे तिला वाटेल घोड्यावर, गाढवावर, वाघावर, सिंहावर, फ्रँकेनस्टाईनवर, अनोळखी माणसावर बसणं हे मी अगोदरच करत होते आणि हे करायला काहीच हरकत नाही. आणि उद्या बायचान्स समोर खरा वाघ आला तर ती त्याच्या अगदी मांडीवर उडी मारेल. वाघ येणारच नाही, आता वाघ राहिलेच नाही. पण अनोळखी माणूस जरी आला तरी तिला तर तेच वाटेल, कुणाच्याही मांडीवर बसायचं, कुणाच्याही गळ्यात हात घालायचा. कोणी गळ्यात हात घातला तरी चालतो. हा खरा हात आहे की आर्टिफिशियल हात आहे? मी खरी आहे की मीच खोटी आहे? आई खरी आहे की आर्टिफिशियल आहे? हेच कळणं होणार नाही. आणि our genes have not coded for this. It would take another 150 million years for our genes to be able to deal with this. अरे हे आर्टिफिशियल आहे, हे रियालिटी नाही. हे 3 महिन्याच्या मुलाला कळण्याचे आत्ता तरी जीन्स आपण पास ऑन नाही केलेत. आत्ता तरी हे जीन्स पास ऑन होत नाही आहेत, कारण नाहीच आहेत असे जीन्स. असे जीन्स डेव्हलप करायला एक 10,000 वर्ष लागतील. पण आता 10,000 वर्ष नाही, 10 महिन्यात हे होत आहे. तेव्हा हे केल्यामुळे वी आर पुटिंग अवर चिल्ड्रन अवे फ्रॉम रियालिटी ऑन AI. But the other problem is today parents are also becoming, children are being born to older parents. Where do they have time to indulge the child? Older parents have less physical energy, less time to go to Kaki Maushi. Kaki Maushi is already in the old age home by now. Who will play with the child? Who will spend time? More reason to stay indoors and show AI. And hence AI will confuse the boundary between artificial world and real world. And this generation is at huge risk of not understanding basic normal human behavior as we have understood over 6 million years. And hence, as IPNs, our biggest concern will be that children will struggle to differentiate natural issues from artificial issues. So what are the solutions? I have a 5-point agenda for IIP, which I want all of us to improve, work on, and that 5-point agenda can become 10-point or 4-point, but it has to become a 50,000 pediatrician agenda. First, we should tell all our pediatricians की हे आपण जे बोलतो ना, अरे मुलं आहेत ती तर मोबाईल बघणारच, आपण प्रोग्रेसिव्ह राहिलं पाहिजे, दे आर डिजिटल नेटिव्ह. अरे कसलं डिजिटल नेटिव्ह? अंजली मॅडम, तुमचं गाव कोण? तुमचं नेटिव्ह प्लेस काय? गोकर्ण. मग तुम्ही कुठले नेटिव्ह? मग तुम्ही नेटिव्ह कुठले आहात? गोकर्णचे. मी कुठला नेटिव्ह आहे? चिपळूणचा. चिपळूणचा नेटिव्ह म्हणजे काय? माझे 4 फादर्स चिपळूणला राहायचे. चिपळूणला काय करायचे? 200 वर्षापूर्वी शेती करायचे. IT इंडस्ट्रीमध्ये होते का 200 वर्षापूर्वी? माझे पणजोबा IT मध्ये कोडिंग करत होते का? की हे IT प्रोग्रामिंग करत होते का? मग मी त्यांचा नेटिव्ह कसा? डिजिटल नेटिव्ह हा शब्द आला कुठून? अमेरिकन इंडस्ट्रीच्या मार्केटिंग मशीन मधून. सो दॅट यू आर ऑल कन्व्हिन्स की नो 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 डिजिटल नेटिव्ह. डिजिटल नेटिव्ह किती छान वापरतोय माझा मोबाईल. सिगरेट द्या ना, छान ते पण उडेल तो. मग सिगरेट नेटिव्ह म्हणायचं का आपण? टोबॅको नेटिव्ह. त्याला चरस द्या, गांजा द्या, त्याला फुकवायला ते लगे फुकेल. मग आपण म्हणायचं का इज अ नॅर्कोटिक नेटिव्ह. म्हणूया आपण तसंच. अल्कोहोल द्या, नाही नाही, तो पितो बघ, किती छान पितो माझा मुलगा, वॉडका दिलं की लगेच बाटली पितो. तो अल्कोहोल नेटिव्ह आहे. कसलं हे डिजिटल नेटिव्ह, कसलं काय? सर्व अमेरिकन एजेंडा आहे, सो दॅट यू बाय a mobile for your child when your child is 6 months old as compared to 18 years old. 12 years, 18 years more गिराईक, 18 years more digital gadget sale, more AMC maintenance, more gadgets, 18 years more business each company is getting from each person, because now at 6.5 months you have to buy something rather than at 18 years. किसका बिजनेस बढ़ रहा है? Instead, pediatricians must mandate to tell the parents the importance of engaging their child with their families and the joy of human engagement. This should be forcibly made for all pediatricians. Third, we must make this Ministry of Childhood and Adolescence that Dr. Ambedkar sir and we have been talking about, which will घेराव the ministers or घेराव the government or whatever, not घेराव, sorry, I take back my words. आजकाल असं कोणी ऐकलं तर उद्या तुरुंगात जायचो मी. We must convince.
Lobby.
We must convince. We must sweetly convince. We must sit and cajole and convince our leaders that they need to keep parks and open spaces for children close by. But one thing which we must fight for is to definitely go to schools and tell them don't have IT inside the classroom, because parents now feel, earlier they used to feel की याचं म्हणजे बोललं तर ऍडमिशन होईल, कारण ऍडमिशन मध्ये इंटरव्ह्यूला काय विचारतात, नाव सांगा, say ABCD 1 2 3 4. So parents were not interested whether the child is peeing in his pants or not. They were interested ABCD आना चाहिए. क्यों? फिर स्कूल में इंटरव्यू देगा तो सिलेक्ट होएगा, स्कूल जाएगा तो मैं जॉब पे जाऊंगा. Now your child is shown IT in the school. So now only having your child ready to say ABCD, it is not enough. Your child has to be able to use mobile, हो की नाही? नाही तर त्याला ऍडमिशन कशी मिळणार? मग आता घरातच त्याला, मग त्याला 6 महिन्याला लावून द्यायला पाहिजे, फोन विकत घेऊन दिला पाहिजे. All this nonsense is getting passed down to parents. They are being pressurized. So schools have to be told to stop this. But the most important dynamic 1 point silver bullet which will change everything is we have to understand parents are helpless. They have to earn a livelihood. Both parents have to work. Single parents चे तर गतच वेगळी आहे. नो फॅमिलीज अराउंड, कारण आईला सासू चालत नाही, एक्सेट्रा एक्सेट्रा. फेअर इनफ. सासू नाहीच आहे, कारण मी आहे मुंबईला, आजी आहे चिपळूणला किंवा कलकत्त्याला, आणि फॅमिली इकडे आहे. शेजार नाहीच आहे, कारण सर्व शेजारी आपल्या आपल्या व्यापात बिझी आहेत. मग नर्चरिंग कोण, केअर द्यायचं कोणी? IAP नाही. तुम्ही बसणार आहात का मुलाच्या घरात त्याला नर्चरिंग केअर द्यायला? नाही. मग त्याला नर्चरिंग केअर कुठे मिळू शकतो? एकच ठिकाण राहिलं, शाळा. म्हणून शाळेला सांगायला पाहिजे की तुमचं बायनरी विच इज ऑपोजिट ऑफ नर्चरिंग केअर. नर्चरिंग केअर इज नॉट बायनरी. मुलाने चूक केली त्याला आपण नापास म्हणतो का घरात? नाही, अरे बाबा पुढच्या वेळी नको करू. नीट पहिल्यांदा मूल चालताना पडला तर नाव यू हॅव फेल्ड, नाव गो टू थेरपी आपण करतो का? अरे नाही, अरे पडत 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 चालायला शिकेल, पडत 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 चालायला शिकेल, कळत 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 समजेल. ह्याला आपण मराठीत म्हणतो घडवणं. आता ह्याच्यात इंग्लिशमध्ये मला शब्द सापडला तर द्या कोणीतरी, कारण मला इंग्लिशमध्ये कुठे हे स्पीच द्यायचं असेल तर मला तो शब्द, कारण घडवण्याचा जो शब्दाचा अर्थ आहे, बोध आहे, तो मराठीतच मी सांगू शकतो. हे घडवायचं जे आहे दॅट इज नर्चरिंग केअर.
मेंटॉरिंग.
मेंटॉरिंग इन अ पॅशनेट, स्लो, स्टेप बाय स्टेप मॅनर, दॅट इज नर्चरिंग केअर. आणि ते जर शाळेतच आपल्याला द्यायला लागेल, कारण शाळेत फक्त जर बायनरी करत राहिलो तर नर्चरिंग केअर देणार कोण? सो वी विल हॅव टू कम अप बाय एक्सप्लेनिंग टू स्कूल्स दॅट प्लीज डोंट स्टार्ट E इज इक्वल टू MC स्क्वेअर इन ज्युनियर KG. त्याला नाही आलं EMC इज इक्वल टू MC स्क्वेअर ज्युनियर KG मध्ये, तो आईन्स्टाईन नाही झाला तरी चालेल, पण लोकांशी वागायचं कसं, त्याला नॉर्मल माणुसकी येणं गरजेचं आहे, ते तुम्ही करा. आता NICU मध्ये आपल्या सर्वांचे NICU आहेत. सर्व आपण हाय रिस्क बेबी डिस्चार्ज करतो. 6 मंथ ओल्ड बेबी 800 ग्रॅमवर अगदी व्यवस्थित सर्वाइव्ह होऊन जातो. आणि मग जाताना त्याच्या कार्डावर आपण काय लिहितो? फॉलोअप फॉर व्हॉट? सांगा. फॉलोअप फॉर
डेव्हलपमेंट,
न्यूरो डेव्हलपमेंटल
अर्ली
असेसमेंट.
न्यूरो डेव्हलपमेंट.
करेक्ट. आणि
ओई बेरा
ओई बेरा आणि ग्रोथ चार्ट,
ग्रोथ चार्ट.
आरओपी
येस येस.
आणि
And
मोस्ट
development
इम्पॉर्टंट
chart.
आणि मोस्ट इम्पॉर्टंट वॅक्सिन.
वॅक्सिन असो.
आपण एवढं सर्व त्या डिस्चार्ज कार्डवर लिहितो हाय रिस्क मुलाच्या. आता मनोहरजी वाचा काय लिहिलं पाहिजे.
स्क्रीन फॉर आरओपी,
Limit a child
ऑडिओमेट्री,
exposure to
ग्रोथ
digital.
चार्ट्स,
हे
वॅक्सिन.
झालं. आता नवीन काय लिहायला पाहिजे.
Limit your child's exposure to digital world. Eliminate as many forms of digitalization as possible. Buy lesser gadgets.
आणि काय लिहायला पाहिजे.
Provide a safe folding. Show children the value of human engagement, especially with their extended family and friends.
हे IAP मधून मॅन्डेट करून यायला काय लागेल आपल्याला ते केलं पाहिजे. आणि IAP मधून डायरेक्टिव्ह आला पाहिजे की हाय रिस्क मध्ये तुम्ही जसं लिहिता की आरओपीचं तुम्हाला मॅन्डेटरी आहे, तुम्हाला ग्रोथ चार्ट मॉनिटरिंग मॅन्डेटरी आहे, वॅक्सिन्स मॅन्डेटरी आहेत, त्याचप्रमाणे असं लिहा. कारण असं जर लिहिलं नाही, एखाद वेळी पोलिओ झाला तर एक पाय अपंग होईल, पण जर हे मिळालं नाही तर पूर्ण मूल अपंग होईल आणि समाज अपंग होईल. आम्ही पेरेंट्सना कधीच सांगत नाही की अमुक तमुक तमुक क्लासला घाला. तुम्हाला विचारतील स्विमिंगला घालू का, अरे मग स्विमिंग बरोबर डायव्हिंग करू का, मग म्युझिकला टाकू का, मग तबल्याला टाकू का, मग गिटार क्लासला टाकू का, अबॅकसला टाकू का. कशातही टाकू नका, कारण प्रत्येक क्लासमध्ये टाकल्यावर दॅट चाइल्ड इज बिकमिंग ऑब्सेस्ड विथ हिमसेल्फ. अबॅकसमध्ये पहिला आला पाहिजे मी, स्विमिंग पण माझं चांगलं झालं पाहिजे, मला गिटार पण चांगला वाजवता आला पाहिजे, मला पेंटिंग पण चांगलं कर. मी 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 everybody is becoming more self-obsessed and hence more isolated and hence even less chance for human engagement. So very important that at New Horizons we did one small study during COVID. आणि ॲक्च्युली बिचारी शीतल आमटे ती गेली, पण तिच्या मुलाबरोबर आम्ही हे केलेलं की तिला कोणीतरी सांगितलं ऑटिझम आहे, मग मंदार फणसेने तिला माझ्याकडे पाठवलं. मी त्या भेटलो पण नाही मुलाला, तिच्या हिस्ट्रीवर सांगितलं हे काही नाही डिजिटल ॲडिक्शन आहे. तर मला म्हणाली कसं मी करू याचं डिजिटल काय. तर ती राहत होती आनंदवनला, तुम्हाला माहिती आहे आमटे फॅमिली. ती म्हटलं की तू एक काम कर, तिकडे 6 आयांना घे आणि एक ग्रुप कर आणि प्रत्येक आईला एका आईला एव्हरी डे 2-3 तास लवकर सोड, तूच ओनर आहेस तिकडे आनंदवनला. तरी मग करते आणि सर्व मुलांना त्या आईच्या घरी पाठवा. मग तिकडे एखादी आई असेल नंदुरबारची, तर सर्व मुलं त्या नंदुरबारच्या आईकडे जातील. मग तिने नंदुरबारची काहीतरी खाणं बनवावं, तिकडचे खेळ शिकवावे, तिकडच्या भाषेत बोलावं, तिकडची मस्ती करावी. दुसऱ्या दिवशी दुसरी आईकडे जावं, ती आई नंदुरबारवाली परत जॉबला फुल टाईम. नेक्स्ट डे द अदर मदर विल टेक 2 hours ऑफ. ती असेल आमच्या रत्नागिरीची, तर ती रत्नागिरीचा खाऊ देईल, ती रत्नागिरीची एक खेळणी दाखवेल, ते रत्नागिरीचे खेळ तिने लहानपणी शिकवलेले करेल, मुलं ते करतील. असं करत करत आठवड्यातून तुम्हाला एकदाच 2 तास ऑफ द्यायचा एका व्यक्तीला. 15 दिवसात सर्व मुलांचा स्क्रीन टाईम 0 झाला, कोणी स्क्रीन मागत नव्हतं. पण गंमत म्हणजे शाळेतल्या टीचरने हा सर्व आयांना बोलवलं, बोले आता काय कंप्लेंट आहे, दरवेळी तुम्ही कंप्लेंटच असते आमच्या मुलाची. पण यावेळी कंप्लेंट नाही आहे, यावेळी कमाल आहे की तुमची मुलं एवढी 15 दिवसात चेंज कसा आला. आता पुश करत नाही, भांडणं करत नाही, शांत बसतात, दे वेट फॉर देअर टर्न, आरडाओरडा करत नाही. तुम्ही नेमकं केलं काय. हे केलं, वी गेव दो चिल्ड्रन बॅक टू नर्चरिंग केअर. आणि म्हणून आंबेडकर सरांनी ग्रुप प्रॅक्टिस डॉक्टरांची म्हणे चालू केली की डॉक्टर शुड प्रॅक्टिस इन अ ग्रुप. आपल्याला पालकांचे ग्रुप केले पाहिजे आणि पेरेंटल ग्रुप प्रॅक्टिस सुरू करायला पाहिजे. तेव्हा पालकांना अशी ग्रुप प्रॅक्टिस करायची कशी शिकवा. आमच्याकडे ऑटिझमच्या येणाऱ्या मुलांना कुठे काकी मावशीकडे पाठवायचं, कारण काकी ओरिसाला आहे, मावशी दिल्लीला आहे. आम्ही मुलांना चक्क गुरुद्वारात पाठवतो, कारण बिचारी तिकडे कोण ऑब्जेक्शन घेतच नाही, दिवसभर उडी असतं, मोकळी जागा असते, शांत निवांत असतात सर्व. सो चाइल्ड इज एबल टू गेट लिटल रिलॅक्स टाइम. बट द मोस्ट इम्पॉर्टंट थिंग, गुरुद्वारात लंगर असतो आणि लंगर म्हणजे चीफ मिनिस्टर जरी पंजाबचा असेल तो तिकडे बसतो, तो पोळी भाजतो, चपला साफ लोकांचे घेतो, चपला बूट साफ करतो, चीफ मिनिस्टर असेल तरी. म्हणजे सेवा, म्हणजे दुसऱ्या लोकांची सेवा करायची. मुलं तिकडे ही शिकतात. आम्ही सांगतो की तुम्ही बिल्डिंगमध्ये आहात, काकी चालले म्हातारी, हातात बॅग आहे, अरे जा तिची बॅग घे. आजोबा आहेत, जा त्यांची बॅग उचल. सध्या मुलांची शिस्त अशी आहे की आता माझ्या क्लिनिकमध्ये इकडे बघा 3 खुर्च्या आहेत, तिकडे 2 खुर्च्या आहेत, वॉटेवर तुमच्याकडे पण त्या असतील. आई बाबा मुलगा आणि आजोबा आले तर पहिले मुलगा बसतो, नंतर आई बसते, नंतर तो बाप बसतो आणि बिचारा आजोबा उभा असतो. मी बोलतो उठ उठ, असं मी हात टोलतो, बोलतो उठा. त्यांना हर्ट होतं, पण त्यांना कळलं पाहिजे उठा म्हणजे माझी खुर्ची खराब होत नाही, मला हे चालणार नाही. आजोबांना बसवा आधी. का? आता ज्या मुलाला तुम्ही ही शिस्त शिकवाल किंवा मदत करायला शिकवाल, त्या आजीची बॅग उचल रे, त्या आजोबांची बॅग हातात घे. शाळेत गेल्यावर टीचर आहे, टीचरच्या हातातून कधीतरी पुस्तक पडलं, मुलं काय करतात? सर्व मुलं असतात, त्यांना गंमत वाटते, टीचर चिडते. हा जो मुलगा आहे त्याला सवय आहे, तो जाऊन बिचारा पुस्तक उचलतो, टीचर हे घ्या, टेक दिस. आता गंमत होते. टीचर म्हणते हाच एक चांगला मुलगा, बाकी तुम्ही सर्व नालायक आहात. टीचर वळली बोर्डावर लिहायला, हाच मुलगा राहून इतरांना मारतो. टीचर वळते बघते सर्वांची मारामारी चालू आहे. टीचर सर्वांना पनिश करेल एक्सेप्ट वन चाइल्ड. कोण तो? ज्याने तिला उचलून पुस्तक दिलं, त्यानेच मारामारी सुरू केली असेल. पण आता टीचर त्याला ब्लेम करणार नाही, बाकी सर्वांना ब्लेम करेल. का? का?
इम्प्रेशन चांगला झाला.
कशामुळे?
मदतीमुळे.
मदतीमुळे,
एम्पथी.
एम्पथीमुळे. आणि म्हणून द मेन मंत्र फॉर पेरेंट टुडे दॅट आय वॉन्ट टू एक्सपाउज इज टीच युअर चिल्ड्रन सर्व टू सर्वाईव्ह. तुमच्या मुलाला हार्वर्डची डिग्री असेल, IIT असेल, काडीचा उपयोग नाही. मेनी ऑफ द हाफ ऑफ द सुसाइड्स आर फ्रॉम IIT और इन इंजिनिअरिंग कॉलेजेस और मेडिकल कॉलेजेस. तुमच्या मुलाला करोडो रुपये तुम्ही ठेवून गेलात, त्याचा काही उपयोग नाही, तो चर्सी होईल, ड्रगिस्ट होईल, काही होईल. पण तुमच्या मुलाला कोणीही सांभाळणार नाही, कारण तो कोणाच्याही उपयोगाचा नाही. त्याचे पैसे वापरून झाले की लोक त्याला लाथ मारतील. त्याच्या डिग्रीचा उपयोग करून झाला की कोणाला त्याच्याशी घेणं देणं नाही. समाजात फक्त जो दुसऱ्याच्या उपयोगाचा असतो त्याला कधी समाज टाकत नाही. हेमंत जोशी आणि अर्चना जोशी आजीवन अमर आहेत, कारण त्यांना कधीही कोणी, त्यांच्यामुळे लोकांचा फायदा आहे. म्हणून त्यांना कधीही लोक पोझिशन असो, प्रेसिडेंट असो, पास्ट प्रेसिडेंट असो, सध्या जे चाललंय कोणाला पडलेली नाही त्यांची पोस्ट. काय? वाय? वाय? बिकॉज एव्हरी टाइम ही इज ऑर शी इज डुईंग समथिंग. आणि मी फक्त त्यांचंच म्हणत नाही, आपण सर्वच आहात. एक उदाहरण म्हणून म्हटलं, सर्व टू सर्वाईव्ह. तुमच्या मुलाला जर ऑटिझम असेल, प्रधानमंत्री मोदीजीने फतवा जरी काढला की प्रत्येक मुलाला इन्क्लूड केलं पाहिजे वर्गात, आणि त्या ऑर्डर प्रमाणे वर्गात बसवला, सर्व मुलं दे विल ऑल मेक अ बॅड फेस, ऑल पेरेंट्स विल मेक अ बॅड फेस, टीचर विल मेक अ बॅड फेस. प्रधानमंत्र्यांनी सांगितलं म्हणून त्याला बसवायला दिला मी इकडे. इज दिस इन्क्लुजन? दिस इज वर्स्ट फॉर्म ऑफ एक्सक्लुजन. प्रधानमंत्रीने जरी रूल काढला, मिलिटरी रूल जरी लावला, तरी तुमच्या मुलाला कोणी इन्क्लूड करणार नाही इफ ही इज ट्रबलसम टू देम. The only way people will include your child is if he is useful to them. So most important thing, you have to focus on how your child can engage with others and help others, and that can come only from human engagement. So to conclude, my definition of nurturing care is the child who gets an opportunity to learn to adapt to different practices. एक चिपळूणची मावशी, एक जालन्याची काकी, एक दिल्लीची आत्या, एक बंगालची मावशी, डिफरंट प्रॅक्टिसेस, डिफरंट कम्युनिटीज, डिफरंट रिलीजन्स, डिफरंट स्टेट्स, डिफरंट रिजन्स, बट स्टेप बाय स्टेप बाय स्टेप बाय स्टेप, स्लोली. फर्स्ट नोन, देन distant, then further distant, slowly, without being judged, no right or wrong, pass or fail, helps the child develop self-regulation better. Secondly, Kaki, Maushi, Atya, Mami are far more important than Dr. Samir Dalwai, developmental pediatrician, or any psychologist or any teacher or anybody. डॉक्टर एक चांगला डेव्हलपमेंट पिडियाट्रिशियन सांगा ना, डॉक्टर एक चांगला सायकोलॉजिस्ट सांगा ना, एक चांगला थेरपिस्ट द्या ना, एक चांगलं औषध द्या ना. नन ऑफ देम आर एनी मॅच फॉर दॅट चाइल्ड्स काकी, मावशी, बुवा, आत्या. नो डेव्हलपमेंट पिडियाट्रिशियन कॅन डू एनिथिंग मोर देन व्हॉट दे कॅन डू. कारण मी तेवढं चांगल्या भव्य क्लिनिकमध्ये टाकून बसलोय वगैरे वगैरे, हे आर्टिफिशियल आहे, कृत्रिम आहे, लाईक आर्टिफिशियल इंटेलिजन्स. इथे शेप सॉर्टिंग शिकवलं, त्याचा जन्मजात बाहेर रस्त्यावर उपयोग नाही, काडीचा उपयोग नाही. कलर मॅचिंग करा, ABCD बोला, हा इकडे बोलतात सर्व, खाली रोडवर उपयोग नाही त्याचा. दॅट ओनली काकी मावशी आत्या मामी कॅन टेल यू की विविधता काय असते, विभिन्नता काय असते. आणि विभिन्नता शिकायची असेल तर समाज, पण समाजात प्रथम स्वतःची काकी स्वतःची मावशी, बिकॉज शी इज क्लोजर टू युअर मदर. सो यू लर्न फ्रॉम युअर मदर, देन सक्की मावशी, देन चुलत मावशी, देन लांबची मावशी, देन शेजारची मावशी, देन शाळेतली मावशी हु इज द टीचर. ओनली दॅट वे कॅन चिल्ड्रन डेव्हलप अँड लर्न. अँड हेन्स गोईंग अहेड, stop making excuses. Don't think that Mahatma Gandhi did not have a school which was IT enabled. आणि महात्मा गांधी नाव काढून कुठलंही नाव टाका. None of them went to a school which was IT enabled. Nobody in this list of attendees just now went to an IT enabled school or went to a school which had IT or had computers. Is any of you feeling horrible in life or terrible in life, as a misfit in life? की तुमच्या वेळी IT शाळेत नव्हता म्हणून तुमचं प्रचंड नुकसान झालं? अजिबात नाही. हे सर्व मार्केटिंग गिमिक्स आहेत. आणि इट्स व्हेरी इम्पॉर्टंट that it takes a neighborhood to make a citizen and takes social engagement to make a normal social brain. It is not just the genes, it is the environment. If you take away human engagement, you will end up with children with problems. आपल्याकडे सावरकरांना कोण आपल्या अंदमान ला पाठवलेलं होतं, बहादूर शाह जफरला काला पाणी. वर्स्ट पनिशमेंट कोणाला दिली जाते? वर्स्ट पनिशमेंट ज्यांना सर्वात जास्त क्राईम मानलं जातं, तेव्हा फ्रीडम फायटर्सना वर्स्ट क्रिमिनल मानायचे ब्रिटिश. त्यांना कुठे पाठवलं? कालापानीमध्ये. कालापानी म्हणजे काय? सॉलिटरी कन्फाइनमेंट. यू कांट सी अदर ह्युमन बिंग्स, यू कांट कनेक्ट टू पीपल. दॅट इज पनिशमेंट. काळोख, पनिशमेंट. आणि द वर्स्ट क्रिमिनल्स वर सेंट देअर. आत्ता आई वडील 2-2, 3-3 लाखात हे विकत घेत आहेत. ह्याला वी म्हणतात काहीतरी. ते मुलाच्या डोळ्यावर घालायचं, त्याने बटन प्रेस केलं की त्याला वाटेल ते वातावरण त्याला दिसू शकतं आणि त्या वातावरणात कसं काय करायचं ते करू शकतं. स्वस्त आणि टिकाऊ उपाय ह्याच्यापेक्षा चरस देणे, गांजा देणे, कोकेन देणे स्वस्त तरी आहे. पण फरक असा आहे की त्याने फिजिकल हार्म होतो हे लोकांना कळतं. ह्याच्यात फक्त मेंटल हार्म होतो, त्याच्यात कोणाला काही पडलेलं नाही, कारण तेवढा वेळ आपल्याला फ्री मिळतो. AI इज एलिमिनेटिंग ह्युमन एम्प्लॉयमेंट अशी बऱ्याच लोकांची ओरडा आहे. पण वर्स्ट, AI इज एलिमिनेटिंग ह्युमन एंगेजमेंट. हे किमान पिडियाट्रिशियन्सना कळावं आणि पिडियाट्रिशियन्सने बोलावं आणि लोकांचे एक्सक्युजेस स्टॉप करावे. आय एम जस्ट गोइंग टू शो सम स्क्रीनशॉट्स. ह्याचे तुम्ही फोटो घ्यावे आणि बरेचसे व्हिडिओज तुम्हाला मी पाठवत असतो, तुम्ही स्वतः डाउनलोड करू शकता. हे QR कोड फॉलो करा. हे बरेचसे QR कोड्स मी इथे दाखवतोय. ह्याच्यात हे सर्व व्हिडिओज आहेत, हे सर्व टॉक्स आहेत. हा तो सोशल स्ट्रक्चर नेबरहूडचा एक लेक्चर म्हटलं मी मगाशी, एक आर्टिकल होतं, त्याचं तुम्हाला हवं असेल तर तुम्ही स्क्रीनशॉट घेऊ शकता. आणि मोस्ट इम्पॉर्टंट, IAP हॅज टू लीड द नॅशनल मुवमेंट फॉर मेकिंग इंडिपेंडंट मिनिस्ट्री ऑफ चिल्ड्रन अडॉलसंट्स. कारण जोपर्यंत विमेन अँड चाइल्डमध्ये अटकलेले आहेत, वोटर विमेन आहेत, आज आपण जे बोललो ते तर खूप लांबचं आहे. नॉर्मल गोष्टी मुलांसाठी व्हायला पाहिजे त्या होत नाही आहेत. सो आंबेडकर सरांची आणि आमची कल्पना आहे की ही मिनिस्ट्री व्हायला पाहिजे. आणि म्हणूनच शेवटी हा सर्वांचा आवडता नट आणि आवडता चित्रपट मुकद्दर का सिकंदर, रोते हुए आते हैं सब. आपण पिडियाट्रिशियन आहोत, आपल्या हातात जी मुलं जन्माला येतात ते सर्व रडत येतात अशीच आपण अपेक्षा करत असतो की अभी कॉल आहे गायनॅक डिलिव्हरी लेबर कॉल, होपफुली द चाइल्ड शुड कम क्राइंग. तो रोते हुए आते हैं सब, मगर एज अ पीडियाट्रिशियन अपना काम ऐसा हो कि उसके बाद बच्चा रोना बंद करे और हंसता हुआ जिंदगी भर जिंदगी उसकी कटे. उसके लिए पीडियाट्रिशियंस को कुछ करना है. तो दैट इज अवर ट्रू डेस्टिनी, अवर ट्रू दायित्व. एंड लेट अस ऑल वर्क टुवर्ड्स क्रिएटिंग अ वर्ल्ड वेर वी पुट चिल्ड्रन फर्स्ट. फॉर दैट we should focus on having quality academics in pediatrics like IIP Palghar always does. And that is the way we will have done our job as pediatricians. Namaskar. Thank you very much.
Fantastic.
वंडरफुल.
Thank
खूप
you.
छान, खूप छान सर.
Thank you.
मला वाटत नाही की याच्यापेक्षा अजून सोप्या भाषेत म्हणजे तू कोणी सांगू शकेल की मुलांचं नर्चरिंग कसं करायला पाहिजे. तसं म्हणजे एखादं झाड वाढवायचं असेल तर त्याला उन्हामध्ये आपल्याला वाढवावं लागेल. मोठ्या
Correct.
झाडाखाली लहान झाड किंवा रोपटं वाढू शकत नाही किंवा ते घरात वाढू शकत नाही. जर तुम्हाला झाड बनवायचं असेल आणि मोठं झाड बनवायचं असेल तर त्याला तुम्हाला बाहेर काढावं लागेल. त्याचं सोशलायझेशन वाढवावं लागेल. त्याचे इंटरॅक्शन्स वाढवावं लागतील आणि ते काम फक्त आणि फक्त जे आपले फॅमिली मेंबर्स आहेत, जे सराउंडिंग पीपल आहेत तेच करू शकतात, नॉट गॅजेट्स. थँक्यू सर. थँक्यू व्हेरी मच समीर सर.
Namaskar. Thank you so much.
Yeah,
Any
Samir, I
questions?
think Finland has stopped the use of mobiles in schools up till 13 years of age. And Australia has made it that up to 16 years, parents also are not supposed to give mobiles to their kids.
Correct, correct, correct.
आपला
So do you
इंडियन
think something?
IIP ने पण त्याच्यावर बनवायला पाहिजे. ऍटलिस्ट 10 इयर्स पर्यंत तरी देर शुड नॉट बी एनी गॅजेट्स. आता तर असं आहे ना सर की मुलगा जेवण करतो का? हो करतो सर. फक्त त्याला मोबाईल दाखवलं की तो जेवतो. इट इज कंडिशनल रिफ्लेक्स झालाय, म्हणजे ते पाउटिंग रिफ्लेक्स सारखं. म्हणजे जसं ते जेवणाचं घेऊन येतात ना तसं तो मोबाईल मागतो. मोबाईल पण द्या मला. म्हणजे तो असं मोबाईल बघतो, ते भरवतात. म्हणजे ते ऍक्च्युअली तो मोबाईल बघतो आणि पोटात काहीतरी जाते म्हणून जाते, असं होतंय. म्हणजे असं
Correct.
ऑलमोस्ट 90-95% मुलांचं तरी आता सध्याच्या घडीला आहे. म्हणजे ऍज अ पेडियाट्रिशियन मी जे रोज बघतो त्याच्यामध्ये ते सांगतो, हा मोबाईल फक्त आम्ही दाखवतो त्याला, जेवताना दाखवावं लागतं त्याला, नाही तर तो जेवत नाही. ही इज नॉट
Correct.
इटिंग ऍट ऑल. असं
Correct. एक
व्हेरी बॅड.
एक सेकंड, 1 मिनिटाचा एक व्हिडिओ दाखवू का?
हा सर, डेफिनेटली.
हा आता 5,51,000 व्ह्यूज झाले 3 दिवसात.
बापरे.
Let's see whether it plays.
Who wants a smartphone and wants to be on Instagram. How do you navigate that?
Why does Australia have a rule that nobody will be allowed below 16? Because they've accepted the fact that parents have failed and schools have failed to be able to control it at a micro level. My point is, if your child is on Instagram, but if you set up some rules, whatever rules you want, I'm not going to give any rules. Okay, you will do this for half an hour. You will not post pictures of yourself which reveal your identity or reveal your address where you stay or expose your body in some way, and your child is following it and you're able to monitor it, and things are going fine. I don't see any problem. But if you find that your child is now not being able to stick to what has been pre-decided.
But a lot of times, parents can't even track what is pre-decided because they're able to basically mask movement on their phone.
Then don't allow it. If I have a car and I cannot make sure that my child who's taking the car out is not going to kill a few people on the road and harm himself, I won't allow him to have the car.
Let's assume I have a 12-year-old, I have a 13-year-old child who wants a smartphone and wants to be on Instagram. How do you navigate?
So this video is just 3 days old. It has already gone to over 5.5 lakh views, and I have shared it with all of you. I think you have seen it. So it's not that I've said something different here, but sometimes something you can refer, you can send to parents or something. So we need to create that awareness, that circle. From everywhere, the parent has to be told this, because it's very difficult for parents to give that kind of time. So they need that. आपण breastfeeding साठी कितीतरी वर्ष लढतोय. अजूनही 60% मला वाटतं असेल ब्रेस्टफिडिंगचे इन्सिडेंट्स, किंवा 70% असेल, 100% झालेलं नाही. पार्लिमेंटमध्ये बॅन केलं तरी IMS, तर आपण स्क्रीन टाइमसाठी केलंच काय? काहीच नाही केलं. मग ते आपल्याला सुरू तरी करावं लागेल, कारण पालकांच्या मनात असंच आहे की दॅट इज गुड, त्याच्यात वाईट काहीच नाही.
पॅरेंट्स स्वतः बघतात ना, त्याच्यामुळे तर मुलं बघतात.
एक्झॅक्टली.
दे आर फॉलोइंग अस.
So thank you everybody, and my dear home branch now, IIP Palghar, because I'm there. So thank you everybody for the opportunity. Thanks a lot.
Thank you. Thank you very much, sir.
Thank you, Samir.
Thank
This
you.
wonderful talk.
Thank you.
We love hearing you.
Namaskar. Thank you so much.
Great, Samir. Well done.
नमस्कार. तुम्ही जे नेहमी बोलता तेच बोललो मी. Thank you.
Any questions? Anjali madam. Thank you, sir. Thank you very much. Dr. Sushma is not able to log in. So I think I will go to Dr. Anjali Madam for Palghar epidemiology, but already that is covered in between first and second lecture. So I thank you all the speakers, Dr. Saurav sir, Saurav Samantray sir. He told us how we should go for that neurosurgeries, how it is able to helpful for that childrens that are suffering from that new, that is tumor or meningomyelocele children, how we can tackle that disorder with surgery. Dr. Samir Darwai sir explained wonderfully how we should nurture our kids to develop a good future generation, and how we should uh, prevent the mobile gadgets, how we should avoid AI uh, for future generation. Then it is advisable to IIP, central IIP, as a pediatrician, that we should make a rule, or we should make a decision that should be passed to all the pediatrician practitioners and all the parents. We should stop using gadgets till 10 years of age at least, as already Australian and Finland government made the rule for their kids. That's all. Thank you.
Thank you very much, Manohar, for moderating this session. Thank you, all our speakers, Dr. Samantre, Dr. Samir. Excellent deliberation today, both on the brain, but one on the emotional aspect and one on the surgical aspects. So we had a great feast. We missed Dr. Sadhna in the Dr. Sandhya in the talk, but we had more than the fill with Dr. Samir and Dr. Samantre. So thank you everyone for being on the webinar, and we meet again next month with more such exciting topics and great speakers like today. So with this, we end this session. Does anyone have anything to say? Archana, Hemant?
No, Anjali, not really. Thank you for
Yeah.
a wonderful CME today.
Wonderful
Thank you.
CME. Thank you.
Thank
And
you, Anjali. Thank you, Manohar.
Thank
And
you,
as
madam.
usual, thanks to Dr.
Saurav and
Anuradha.
Dr. Samir.
As usual, thanks to Dr. Anuradha Palwankar for getting us the MMC points, and Dr. Jayashree Deshpande and Alka Badbade for being on the panel of committee members. Thank you, everyone.
Thank you, madam. Thank you. Bye.